very nice to see all of you from around the world and participating on the activities of EndoMarch. There is a question from Isabella on TikTok that she's asking, what advice do I give to the patients with endometriosis who are trying to get pregnant? Isabella, I treat every single patient individually based on that patient's goals, and here goal being pregnant. I have to evaluate all the other factors, her partner's factors, her age, her situation, and also her condition, her fallopian tubes, her ovulation, where she lives, what she eats, and also her genetic factors for the treatment of endometriosis. I, in general, like to treat every patient according to her specific case. I don't have a cookie cutter technique. I don't treat every single patient the same. There is a question, I hope I answered your question. There is a question from Leila on Instagram. She says, how hormonal therapies such as birth control pills, hormonal IUDs, helping patients in managing endometriosis, and what are the potential side effects? Leila, unfortunately, hormones, almost all of them, there are some degree of side effects. And again, we have to individualize the care of patients. For example, is a teenage girl, a very young patient in the early years of her late 20s or or in her early 20s or in her late teens, and she wants, she's not planning to get pregnant, then birth control pill is a good idea. The lowest dosage possible is the best idea to take to decrease the side effect as much as possible. The same is with hormonal IUDs. The lower the dosage, it is better. So in general, we have to decide that patient, her weight, her height, and where she lives, and her other factors, and we treat her with hormones. And like birth control pills or IUD, or not everybody obviously can tolerate hormones. On Mohammed from YouTube is, can you elaborate on the impact of surgical interventions such as laparoscopy in managing endometriosis, related infertility or organ dysfunction? In general, surgery by minimally invasive technique is, by a very experienced surgeon, is the best way to address endometriosis, in my opinion, when a patient wants to get pregnant. If the patient is younger, let's say in her 20s and early 30s, in our experience, if the partner's sperm count is good, the best surgical approach, if it is done by minimally invasive surgery and endometriosis is treated very thoroughly, the success in our hands is better than IVF. Much better than IVF, and because IVF by itself, the medication that the patient receives by IVF produce a lot of estrogen, and that could cause endometriosis worse. Sometimes you have no choice. If the patient is older, in mid to late 30s and early 40s, and IVF is the best after surgical treatment of endometriosis. Because in our experience, when we treat endometriosis very thoroughly, the chance of success after IVF is much better. So it all depends on the experience of the surgeons or groups that are treating the patient. In our experience, patients with endometriosis, younger or older, after surgical treatment of endometriosis have better success. For the organ dysfunction, The same way, for example, if the patient has endometriosis on her ureter and it is causing a stricture of the ureter, which could cause silent loss of a kidney, it is better to go ahead and remove endometriosis rather than put the patient on hormones, because if you stop the hormone, endometriosis will keep progressing and patient might end up losing the function of that organ like the kidney. Again, thank you for asking your questions. In the loving memory of Mercedes Valdés, a founding EndoMarch member from Panama, we pay tribute to her indomitable spirit and unwavering commitment to global endometriosis community. Mercedes, a beacon of hope, has left an enduring legacy that will forever inspire and uplift millions around the world. As a pioneering advocate and founding member of the EndoMarch, Mercedes played a crucial role in driving awareness and championing the cause of endometriosis health rights. Her dedication and passion have been instrumental in restoring hope to those affected by this challenging condition. Mercedes' impact extends far beyond borders, and her contributions resonated deeply within the EndoMarch community. Her advocacy, resilience, and compassion have touched the lives of many, leaving an indelible mark on the fight for endometriosis awareness and care. Though she may not longer be with us, Mercedes Valdés' memory will forever live on as a source of inspiration for generations to come. In honor of her legacy, we recommit ourselves to the ongoing fight for endometriosis health rights, ensuring that her efforts and passion continue to make a difference in the lives of those affected. Our thoughts and heartfelt condolences goes out to Mercedes' family, friends, and entire EndoMarch community. May her legacy serve as a guiding light in our collective journey to bringing hope, awareness, and support to all touched by endometriosis.
First, I would like to thank Dr. Neja for this invitation. My name is Marco Pinho Oliveira. I'm a full professor of the Department of Gynecology of the State University of Rio de Janeiro. And today I'm going to talk about robotic surgery for bladder endometriosis. When we are operating patients with endometriosis, we can divide pelvis in the anterior compartment, lateral compartment, and posterior compartment. It's important that the surgeon knows that he knows very well the anatomy. Here we can see a cadaver lab image with the paravesical space dissected, and we can see here the obturator nerve. And here we can see some anatomical landmarks. The bladder, you can see the paravesical space, and that is divided by the obliterated umbilical artery. That's a very important anatomical landmark for this region. And we can further divide the paravesical space into a medial space and a lateral space that we can call the obturatory space. And it's also important to know the pelvic floor muscles, because sometimes you have to dissect up to the pelvic floor for resect endometriosis on the anterior compartment. And here we can see the puborectal muscle that is more inferior and medially located. After the puborectal, have the pubococcygeal muscle and then the iliococcygeal muscle. More laterally, we have the obturator internal muscle. Our group published recently our approach, our systematic approach for the robotic surgery for bladder endometriosis. Most of the time, maybe 95% of the cases, we only use 3 robotic arms, 1, 2, and the third on the umbilicus. 5% of the cases, depending obese patients or some other reasons, to use the third arm. So we use the 4 arms in selected cases, and we put a 5 millimeter for the assistant in this place here. We begin our dissection in the paravesical spaces. We never touch the nodule first, always dissecting the paravesical spaces. Then we can develop the vesical vaginal space, and if it's a small lesion of the bladder, we can do a shaving procedure without opening the mucosa, and the robot can, with the 3D vision, very precise movement, we can do the shaving and avoid opening the bladder when there is no mucosa infiltration. After opening the bladder, we resect all disease, and then we can close with 1 layer suture or 2 layer sutures that we do most of the time. Here we can see a robotic surgery for resect bladder nodule. And we first dissect the left paravesical space. It's important to dissect below the nodule so we can control the lateral part of the bladder. And then we dissect the right paravesical space. In some cases, the round ligament are affected, and after dissecting the paravesical space, we can resect the round ligaments also. After dissecting the paravesical space, we then open the vesical vaginal space, and mobilize the bladder, and then we can resect the nodule. In this case, we did a cystoscopy before surgery, and we knew that the patient had an endometriosis affecting the mucosa. So here we open the bladder and we perform a partial cystectomy. Then we can see here that the suture is very easy with the robot, very precise, and we make a running suture. This is the first layer. And the second layer, we use PDS suture. And here, this suture is finished. In this second case, we have a bladder endometriosis that also affects the right ureter. We have to dissect the ureter very near the bladder, and we can see here that the medial aspect of the space between the ureter and the bladder is infiltrated with endometriosis. Here we have the uterine artery, here the ureter, and here, when we cut the uterine artery and dissect this region, we are in the fourth Yabuk space. And we can see here that the right wall of the bladder near the ureter ocean is infiltrated with endometriosis. In this scenario, we have to remove disease, and we may perform ureteral reimplantation. But in this case, we can see that we are mobilizing the ureter, and there is no disease in the posterior part of the ureter. So we decide to resect all the muscle in the anterior part of the ureter. We can see here the stent, the right ureteral ocean, and here the right ureter, and resect all the disease. And we did not have to mobilize the ureter from this normal anatomy site to another place. So we did not perform ureteral reimplantation. We resect the bladder lesion, and we can use the robot to do a very nice suture. We have to reconstruct the trigon. Here we can see the suture. And also we have to do a suture to close the ureter tunnel. Here we are closing the trigon, and now you see that we are going to make the suture, so we don't need to do a reimplantation in another place. We just let the ureter stay in its normal position. And we can do a anti-reflux technique. Now closing the bladder wall. And close the bladder in 2 layers. And the procedure is finished. The third case that I want to present is also a bladder endometriosis with endometriosis of the ureter. This patient had a previous surgery, and here we can see a very big nodule on the right side of the bladder. And in this case, we have to do a reimplantation because the distal part of the ureter was compromised. And here we are mobilizing the bladder and dissecting the rectal space. This is needed because we have to do a psoas hitch, because we have to resect the ureter, and so the ureter is shortened, and we have to mobilize the bladder in order to reimplant the ureter at the bladder. Here you can see the sutures on the psoas muscle, and here you can see the diseased ureter. We have to cut here, so we have the ureter. You have to make an incision 3 to 4 times the diameter of the ureter. We usually start at 6 o'clock, and then you can do a running suture up to 12 o'clock using 5 or 60 PDS. We insert a double J through the robot, and then into the bladder, to the ureter, and then to the bladder. And now we are closing the detrusor muscle to do an anti-reflux technique. So the procedure is completed. And we put a drain at the final step of the surgery. So some take-home messages is that robotic surgery allows for precise movements, reducing the risk of damage of surrounding tissues during the resection of bladder endometriosis. The precision of robotic surgery typically results in less blood loss, minimizing the need for transfusion and reducing the overall surgical risk. The combination of precision and better visualization often leads to better overall outcomes, including lower rates of complications. The precision of robotic suturing makes ureteral reimplantation an excellent indication. So thank you very much for your attention.
Hello, Dr. Nejat and friends of the endometriosis community. My name is Danica Thornberry. I'm an acupuncturist who's created an online resource for patients going through infertility or endometriosis. And I call it a holistic guide to healing endo, and I'm excited to tell you more about it. Again, I am a women's health acupuncturist and have been since 2001. That means I've worked exclusively with women, women who are trying to conceive, women who have endometriosis, women who go into menopause early as a result of having endo potentially. Those are just a few of the scenarios of cases that I've worked with. I am an endo sister myself, and I've had laparoscopy 3 times. The first time was when I was in college with a resident surgeon who was not informed at that time, back in the 90s, about how to excise endo. My second surgery, however, was in 2004 when I was 34 years old. And at that time, the surgeon that I had knew how to do endo-excision surgery, and I was very fortunate. And at that time, prior to my diagnosis and surgery, I had been told that I was infertile and had a diminished egg reserve, premature ovarian failure, and was on the fast track to an early menopause. All of this was the result of silent endo, which wasn't so silent for me. I was really struggling every month with terrible periods, terrible pain. And it was a matter of finding the right surgeon to do my excision surgery. And I did find him. He's long since retired. And this course is my way of helping as many women as I can to know that there is more you can do, especially if you fall into some of the categories that I'm going to explain in the later slides. So the third laparoscopy was done when I was 51 years old, so postmenopausal, and I had kids back following the second surgery. But as a result of exposure to COVID antibodies and the vaccine, something in my system triggered a new flare of endometriosis in the area where that second surgery was not able to reach, retrouteral. So in 2022, I repeated the laparoscopy for, I think, the last time, as the robotic arm was able to move my uterus aside and my sacrum was cleared and freed of all endo and remaining scar tissue. So, like I said, I am a fertility success story, and as a result of pursuing an endometriosis excision surgery, I was able to conceive 2 children with 1 attempt only and naturally. So I am here to encourage other women to listen to themselves when they feel like there's something not right in their system. But let's talk about acupuncture and its role in an endometriosis patient's life. I specifically want to talk about what it can and can't do. Acupuncturist, I'll be very clear from the beginning, in my experience, it cannot remove adhesions, it cannot correct scar tissue, and it does not work miracles as we would hope that it would to prevent the need for surgery. That's my opinion based on 20 years experience and as a patient herself. What acupuncture can do, though, is it calms the mind, it calms the anxiety, it restores homeostasis, it promotes a flow of endorphins in the system that helps the women to feel like everything will be okay. It also reduces inflammation and helps to manage pain. The women benefit substantially when they go through the surgery. So I don't advise my patients delay their decision to have surgery and to think maybe more acupuncture or more herbs. I feel like that's doing them a disservice, especially as the technology is here with things like the robotic arm and laparoscopy with the endo-excision surgery being available. So sometimes endometriosis presents as pain. That could be the leading symptom, but it often is showing up as unexplained infertility and pregnancy loss. So, as Dr. Najat says, endometriosis is the great masquerader. It presents in so many different ways. It's very confusing, as we all know, and the diagnosis to get to the surgery can take some women 10 years. So, here's just a little visual of the timeline that I put into the course to help women understand the path that they're on. First of all, it's about having the complaints of pain or dysmenorrhea, painful periods, or infertility, pregnancy loss. Then there are the delays to diagnosis, or maybe the different types of treatments that are not correct for her case. Even if they're seeing an acupuncturist, it might not be the right thing that she needs. If she needs surgery, acupuncture is not going to help. To make the decision to go through with surgery, to select the surgeon, to prepare herself mentally, or to pursue another egg retrieval or two to get more eggs in the basket before doing the surgery might be a consideration. Some women need to do the surgery to improve the egg reserve, but these are big decisions, and the course helps women to think it through and have lots of information. So, the course is again called A Holistic Guide to Healing Endometriosis, and it comes from my work that I've done for decades at Well Women Acupuncture and that I present to the fertility patients using seedfertility.com. The goal was to ask the question, what happens when we teach the patients what the doctors are looking for to give a diagnosis of endo? So, to top off the program, we have 10 expert interviews, including Dr. Nejat, fertility specialists Kelly Beck, Catherine De Agarte, and endometriosis surgeons Iris and Larry Orbuck. These doctors were willing to give hour-long interviews for the patients to listen to experts in the field to get an idea of whether or not they need to pursue fertility, pursue endometriosis excision surgery. Let's hear from Dr. Beck how she has a sense that she's working with an endometriosis patient.
So I put it all together, and when I do a physical exam, I know there are certain telltale signs that I can see immediately. Everything in our body should be midline and symmetrical. That's really how we're built. But if the uterus is not midline and it's deviated to the right or the left, that is a hint. If one ovary has a lot more activity than the other, or it's tucked under and is not mobile. When I do a pelvic exam, if the uterosacral ligaments, which are the ligaments that hold up the uterus, are thickened or shortened, and that's a sign that the uterus is deviated towards, that's another sign. What happens with endometriosis, it's a lifelong entity that can cause scarring of the pelvis. And that scarring is why it's manifested in having these thickened ligaments because of the scar tissue that's present. So I put it all together, and when I do a physical...
So Dr. Beck knows that it's about empowering these patients with information, and I bring it to them in the form of education. I want to demystify that excision surgery for them and to help them know how to recover as fast as possible so that they can get back on track with their lives or potentially improve their fertility outcomes or their quality of life. So here you see the first page inside the program that explains to the patients. We have the interviews, we're explaining endometriosis, we're talking about the emotional component, the pain component, and which supplements really do help with pain, as well as how to move their body to help prevent more adhesions. There's a mind-body aspect of endometriosis, and that's where I like to talk about the uterus as the second heart. It's a great metaphor for explaining that repressed emotions will be potentially harmful for our health, specifically fertility. So I also will teach the patients about better boundaries as the endometrial lining has come outside of the uterine wall in these cases with endometriosis. There's a nutritional aspect to the program where we teach the patients how to eat differently according to the hormone interplay during their cycle. Through the 4 phases, there are different foods that they can eat to keep inflammation at a minimum. And here you see a slide showing during the menstrual period what types of food they can eat to help cleanse their body of the unopposed estrogens that's left from the former cycle. So this is very much a holistic form of treatment that the patient has control over. So it's self-led through the means of an online course. Acupuncture can be done as well as part of a healthy lifestyle, along with yoga, the emotional work, being a better gardener to the fertile garden, and eating foods that are anti-inflammatory at the right times of the cycle. Inside the program, we have coaching available, as I am one of the instructors, another acupuncturist, Ellen Ludwig, and fertility, health, and life coach, Larissa Laskin, who was a former fertility patient and is now a mother. All 3 of us are available to help guide the patients to motherhood or through a successful endometriosis excision surgery to relieve pain and improve their quality of life. So the final slide is just a push for the program, Holistic Guide to Healing Endometriosis through seedfertility.com. I've really enjoyed putting this together and giving everyone some insight into this exciting holistic program. I think we all know that surgery alone isn't enough in this multifactorial condition. Women do have an emotional, psychological aspect to endometriosis that also needs healing, as it can do damage to relationships as well as their fertility. So I thank you so much for your time. Thank you for watching this video, and thank you in advance for supporting your patients by recommending the Seed Fertility Holistic Guide to Healing Endo. Thank you. Bye.
Good morning, good evening, good afternoon around the world. Welcome and thank you for joining us for episode 7 of Endometriosis Explained. Ask the experts. Today we will be discussing thoracic endometriosis syndrome. I am Dr. Kamran Nejad, the founder of the worldwide EndoMarch, and joining me are the co-founders, Dr. Sfar Nejad, Dr. Sina Nejad, Dr. Azadeh Nejad, Barbara Page, and also our expert for this session, Dr. Leah Bacchus. Dr. Bacchus is a known thoracic surgeon, surgical oncologist, thoracic specialist, and cardiothoracic surgeon that we are collaborating with for the treatment of our patients with endometriosis. Finally, we are joined today by our wonderful dear patients who are going to share their stories, Abby Kopra, Jessica Schaefer, and Michelle Sundquist. We thank you very much for submitting your questions online. If you did not have a chance to do so, feel free to comment below with your questions, and we will try to answer them at the end of the session with Dr. Bacchus. If you have missed any of our previous webinars and would like to rewatch them about endometriosis of the bowel, bladder, ureter, and infertility and endometriosis, pain and endometriosis, please visit our website at www.endomarch.org and click on webinars at the top. Worldwide EndoMarch is a registered 501c3 nonprofit organization that intends to raise awareness about endometriosis. It has more than 60 chapters around the world. All donations to this philanthropic organization are tax deductible. If you would like to continue to support the webinars and other events like this, please visit our website and click on the Donate Now button on the top right corner. If you haven't already downloaded the free Nejat Endometriosis Advisor app from the Apple App Store or Google Play, and take the questionnaire to assess your risk of endometriosis, please go ahead and do so. Now, we will proceed first with Dr. Sina Nejat and Dr. Far Nejat, that they mentioned some about endometriosis. Go ahead, please, Dr. Sina Nejat.
Good morning, good afternoon, and good evening, everyone. I am Sina Nejat from Atlanta, and I'd like to also thank you for joining us on this webinar. Considering all the participants, the variety, I'd like to just address a bit about diaphragmatic anatomy. It's a Greek word. Dia means a part and fragment means fence. And we look at it, it separates chest from the abdomen. It is very important to know the structure of the diaphragm, that it has 3 parts, and the texture of the diaphragm varies based on its location, the thinness, thickness, the relationship to the pericardium and phrenic nerve. These are the actual pictures of diaphragmatic endometriosis that you can see on the left of your screen. You can see the thin part with the small lesions. On the right of your screen, you can see more of a typical fibrotic on the surface of the macularis. As I mentioned, the relationship to the phrenic nerve, also the vascularity, and the pericardium, it would affect the decision of how to treat these pathologies. These are the largest case series that's been reported. Of course, we have been reporting diaphragmatic endometriosis since early 90s. We have a large experience, but when you look at them, 80% of them are right-sided. In the other parts, they treat them with cardiothoracic surgery, video-assisted thoracoscopy, but in our centers, we have been able to treat majority of them transperitoneally and occasionally combine video laparoscopy and video thoracoscopic approach. This is a lesion that you can see the liver has adhered to the lower part of the diaphragm. This is a distal part of the diaphragm. And as we explore the lesion, you can see the chocolate-like material protruding. So the appearance is similar to the lesions involving the uterine wall, which is called adenomyosis, or ovarian cortex, which is called endometrioma. So it could have different manifestation. And you can see the endometrioma is removed, and you can see the base of it, which is more of a simple, normal macularis. This is one of the worst cases of the diffuse diaphragmatic endometriosis that I have done. And interestingly, she had 0 symptom when it comes to the area. So the treatment is decided based on the symptom of the patient and or if is structurally could causing any damage, for example, fenestration or phrenic nerve involvement. The next case that I'd like to share with you is the combination that we have taken care of it with video-assisted thoracoscopy. You can see the diffuse lesions, excised. It can be either sutured or using the stapler that other colleagues would address that. The relationship of the diaphragm and the liver is very important. Specifically, the ligament suspends it and could obscure the view. So at times it's important to free these ligaments to have a better access to the deeper part of the diaphragm. This is the diaphragm here on the top. You can see this is a lesion, that this lesion is adhered to the diaphragmatic part, pulling the liver out. In the past, they used to diagnose this as a Fitzhugh-Curtis syndrome, or probably they thought it may be related to the PID, but actually this is a liver lesion that, if you see it here, penetrating deeply into the wall of the liver, creating an endometrioma like that I mentioned. You can see it in actually
the lesion is elevated
here
and
on the
excision is
liver.
performed with the CO2 laser.
So this is a video one of my fellows presented
during this process.
about 20 years ago.
A loculation is then visualized from which the material was released. Excision is completed with the CO2 laser using the suction irrigator as a backstop. Final pathology confirmed endometriosis of the liver.
So the reason I did share this with you, because unfortunately on the internet, they are mixing the instrumentation with the treatment. I heard one of my patients was telling me, oh, using laser on endometriosis is bad because on internet they say whoever is using endometriosis is not excising endometriosis. Well, clearly you cannot write off a device because this person who doesn't know about that energy source would misinform the other patient. Laser, scissors, harmonic, monopolar, these are all tools. It's not the vehicle that gets you there. It's the goal, the treatment, and the destination. So this is a lesion precisely excised from the surface of the liver, separated from the diaphragm, with the laser that you saw. So on that line, I will stop here, and Dr. Farnejad will share with you diaphragmatic endometriosis surgical management. Thank you.
Thank you, Dr. Farnejad. Now, Dr. Sinanejad. Now, this is Dr. Farnejad would demonstrate for you one case of endometriosis which involves diaphragm and also the pleura of the chest.
Good morning, good afternoon, and good evening, wherever you are. It is a pleasure to be here. So this is a young woman that had history of the endometriosis for several years. She was only 24 when she came to us, and she had I'm sorry, how come? Can you see the sharing, the camera?
Yes, I'm sure Tiffany is, yeah, perfect. We see your picture. Yes, excellent.
But she had had 2 prior surgeries. She had had numerous lung collapse, and she had had pleurodesis, and she had been on Lupron for 2 years, and still she had chest pain on her left side, pelvic pain, and whenever she was stopping her hormonal suppressive therapy, she was having pneumothorax. So now we are doing robotic assisted laparoscopic treatment of her pelvic endometriosis and adhesions, diaphragmatic treatment of endometriosis, and our thoracic surgeon takes care of her left chest. Now, this is inside of the abdomen. Now you see she has severe adhesions between the loops of the bowel from her previous surgeries. And here you could see we are using the robotic approach. This is a diaphragm. This is the liver, as Dr. Sinan Nejat showed you. And you could see the liver is attached to the diaphragm, and there are several holes on the diaphragm that had made part of the liver penetrates to the chest. So this is the diaphragm here. You could see endometriosis down here. And here you could see the holes here. And here you could see this part of the liver has endometriosis. This is again robotic approach. And that is the area of endometriosis of the liver, which is going to be excised. Dr. Sinan Nejat showed you excision with CO2 laser. Now we are using electrosurgical scissors for excision. And further, certain area which has some small bleeding, we are going to coagulate them. You don't want to damage the liver a lot. You don't want to excise everything to damage the liver. Here you could see you could coagulate or vaporize. And here you separate the liver further from the diaphragm. These types of the procedure needs a lot of skills in surgery in the upper abdomen. I am a gynecological oncologist, and we take care of cancer of the diaphragm all the time. Now we are looking inside of the chest through the abdomen. You could see this is the liver, and this patient had prior pleurodesis. They have put talc powder in the chest to prevent pneumothorax, but it didn't work. Now you are lysing the scar tissue here further. This is the part of the bowel. You have to be very careful. And it's the liver, immobilize it. Now, all of these holes has to be closed. You check the left side, and the left side it is fine. Now, because we want to cover all of these holes, so we put a mesh to cover all of these holes and prevent a future pneumothorax and collapse of the lung. So here we put the mesh and suture it, the mesh to the diaphragm. The robotic platform makes this procedure easier, although we can do it by laparoscopy too, but the robot makes the suturing easier for the surgeon. And here you can see that part, it is done. So we have taken care of the chest. Now you could see she has severe adhesion between her bowel to get to her pelvis. You could see here, everything is glued together. This is the uterus, the bowel. She had endometriosis of the bowel here. This is the left ovary. And all this endometriosis has to be taken care of. This is the right side, this is the left side, and we took care of all of the endometriosis. You could see everything is free. Now our thoracic surgeon takes over. And now the thoracic surgeon looks on the left side of the chest. And you saw there was blood, bloody fluid on the chest because of the endometriosis. And this is adhesions here that he is going to lyse it to cut down the scar tissue. This is the lung. And the heart is below that. You could see the pulsation of the heart. And this is the pleura. You could see endometriosis on the pleura, and he is excising all this area of endometriosis from the chest wall. Again, this is electrosurgery, that it is going to be excise all these areas from the pleura. This is, again, collaboration between different disciplines to be able to give the best benefit to the patient. You could see the pulsation of the heart moving the, this is the heart down here. You could see the entire area of the pleura has been excised. And the procedure, although was lengthy, but patient did very well. We put the chest tube, and she had significant improvement of her pain. Thank you.
Thank you very much, Dr. Farnejad, for your presentation. That was excellent. The same thing for Dr. Sinanejad. Thank you for your excellent presentation. Now we proceed with our dear patients, and Dr. Azadeh is going to introduce Jessica Schaefer and also Abby Kopra. Go ahead, Dr. Aziz. Hello? Okay, if Dr. Azinejad is not available, let's go ahead.
I think she's just muted. She's muted.
Yeah. Proceed, please.
Okay, why don't we proceed with Jessica? Jessica is, I let her tell her story, and after Jessica, we will proceed with Abby. We thank both of them very, very much for being willing to share their story to help other patients and raise awareness about endometriosis. Jessica, please proceed.
Hi, everyone. Okay, so growing up, I had completely normal periods, and it wasn't until I got the Nexplanon birth control implanted that a month later, I had a cyst growing on my right ovary, and I went into surgery and had it removed. And after that, my periods were never the same again. And since I had experienced what a period's supposed to be like, I definitely knew there was something going on. And I continued to go to doctor after doctor and just kept being told all your lab work was coming back normal, everything checked out. Nobody could figure out what was going on, why cysts kept on reoccurring. And I started to have debilitating cramps, and at one point, I was even told that I don't have endometriosis. And like so many others, I was unaware of what endometriosis even was. So, doctor told me I didn't have it. And of course, I believed that and just went forward and continued on trying to find answers. And it wasn't until last year that I finally went back to Houston, and I had a primary physician there that I had gone to years ago. And when I went in with her, within minutes of me telling her what I had been going through the last 5-6 years, she immediately was asked about endometriosis. And I told her, well, no, they told me I didn't have it. And she said, well, how were you diagnosed with it? And I said, well, they did a pelvic exam and an ultrasound, and that was everything that took place in that appointment. And she's like, she immediately referred me to an OBGYN that got me in and explained to me that the only accurate way to get a diagnosis is through surgery. And at that point, when he did the ultrasound, I had already had another cyst on my ovary. So he was already going to plan to take that cyst out. And he said that whenever he was doing that, he would go through and just check and see if he could find any endometriosis. And again, since I was so unaware, I didn't know that, ablation versus excision. I didn't know that. And for this doctor, he only knew ablation. And so that first surgery, that was March of last year, he went through and burned everything off. And, I always thought, I was like, once I finally have a name to what's going on, I thought, I'd have all these answers and would find relief. And instead, I got the diagnosis, and it only went downhill from there after that ablation. It was basically like fuel to the fire. I had started, the pain was getting worse. I had more symptoms increasing. Everything kept piling on. And that was when he referred me to an endometriosis specialist. And eventually I realized it wasn't a specialist. He was just a fertility specialist who took a couple lectures in endometriosis and then claimed that, hey, I know endometriosis. So what he did was put me on multiple hormone medications. And it wasn't until it was my fourth hormone med that he prescribed me. Or actually it was my fifth one. And then the pharmacist pulled me aside and she asked me, she's like, what's going on? The dose, I've never even had anybody prescribe such a high dose, as well as I was on 2 birth control pills, 2 different types. I was on the Mirena. They were trying anything and everything to get my period to stop, and it wouldn't stop. Sometimes it would even go on for months at a time. And so he was trying to get it to stop and it wouldn't. And whenever she kind of brought it up to me that it was a red flag, I was like, okay. So I put my foot down. I was like, no more being a lab rat. I'm not going to just continue taking all these meds that I don't even really understand what's it doing, because I didn't find any relief. So I decided to go see another doctor. And during that time, it had gotten to the point where I ended up on medical leave, because I would get these cramps that were so sharp that it would cause me to stop breathing. And then once I stopped breathing, my vision would get black. And right before I fully passed out, I would come back to, I could get my breath and I'd be okay. But this went on for a month straight, multiple times a day. So I couldn't drive anymore, because if it happened when I was driving, that could end up in a bad wreck. And then I was also a liability at work if, once I did have a fainting spell at work. So then, they were like, I'm fortunate enough that my boss was so understanding, and he said, you go and take care of yourself first. Once you're back and healthy, you can come back. And so after that, I had found a specialist that could excise all my endometriosis. And then once again, I was back in the OR, and that time when I woke up from surgery, I had been hospitalized and found out that during surgery, my median sacral artery was nicked, and it was centimeters away from my aorta. So I was very fortunate to even make it off the operating table. But when I came back to it, the doctor actually blamed me for it. He goes, your size, you're just so small that, you know, I nicked it because of your size. And I was like, okay, well, and that was, after that, I was then considered high risk. I no longer went to that doctor. I waited a year to get in with a specialist that had patients fly in from all over the world. And so the wait list was extreme. So, you know, I waited that year. And when I got in with him finally, it was almost $2,000 that I had spent to even see him. And he sat me down and he said that I was high risk, that he couldn't help. And he's the one that referred me to Dr. Cameron. And at that point, though, I was pretty devastated. You know, I'd spent all this time getting passed from one doctor to the next, and I just felt like that I was never going to get any help, that, you know, like I kept being told that yours is too severe. And so, you know, it's hard to definitely, you know, go through that. And the moment that I walked into Dr. Cameron's office, I knew right away that I had finally like found the place that I was supposed to be at. Before he sees you, he has you download his app, and it has a questionnaire that you fill out. And during that questionnaire, there was a question that said, do you have right shoulder pain? And I'd had that for years. So when I actually sat down with him, I asked, I was like, hey, like, I've never had another doctor even bring this up. Like, why is that a question? And that's when he explained to me that endometriosis can grow on your diaphragm. And so I brought up, I said, hey, like I get out of breath just walking up a flight of stairs, and, you know, I get shortness of breath where, like, you know, I have to take a huge deep breath to even feel like I can fully breathe. So I was like, is that also a factor for any of this? And, you know, he said, we sat down, I had a long list of questions. He went through every single one of my questions. And at the end of it, you know, we agreed that, you know, for me, the best option was to once again go through surgery. And during that surgery, once I woke up, the first thing he said to me whenever that I can remember, once after anesthesia and everything, he said, you know, none of this was in your head. You know, I did find the endometriosis in your diaphragm. And that surgery was last month. The pain in my right shoulder is significantly better. I mean, there's still like a mild little bit, and I think that's probably residual that I think in the time it'll probably go away. And for now, you know, we have a plan of how we're gonna handle everything going further. And I finally found somebody that's listening, and that actually helped for once. And so with endometriosis, and for me, I have stage 4. I am aware that it can grow back, but knowing that I finally have somebody that I know that I can call and count on to help me through it all, it just changes everything for you. So that's why I'm here doing this. I was so unaware, even within that year of, like, last year of being diagnosed to now, all my research that I had done and my family had done. I mean, we were reading books, we were reading medical journals, you know, everything possible. And I had never even seen diaphragmatic endometriosis until he brought it up. And it just, I just want to do as much as I can to help the next person, so that hopefully they don't have to go through all these years of not knowing and not understanding. And I do believe that if you do catch it in time, you can prevent it from progressing to this extent that I am at now. I think if Zoe, if anyone wants to reach out, I can give her my information. If you guys want to talk, I'm always here. I've experienced it all with you guys. So if you guys ever need any kind of help or support, definitely let me know. And thank you for allowing me to share my story. And thank you, Dr. Cameron. You gave me my life back. You know, like it's great to finally have that back. So thank you.
Thank you very, very much, Jessica, for sharing your story. And that is the purpose of the worldwide EndoMarch, is to raise awareness. All the physicians that you have seen, all of them are good. All the physicians, they like to help people. They have good intentions. They want to help. The issue is what the mind doesn't know, eyes don't see. That is why endometriosis is an enigmatic condition. It is underdiagnosed and misunderstood. That is why your story that you are sharing, we are very thankful. We are raising awareness everywhere, more and more, due to the efforts of Worldwide EndoMarch across the world for the past 7 years. Because of patients like you and because of the Worldwide EndoMarch, people are getting help, and it's going to get better. Now, I don't know if Michelle Sundquist is available, Dashtina. If she is, she can go first. If she is not, we will let another patient of ours, Abby Copra, to present. Is Michelle available?
No, Michelle would like to wait a little bit, go later. So you go ahead, please.
Okay, now we have another patient of ours that we are grateful to her, and she has a very fascinating story. And Abby, please share your story, and the journey with endometriosis.
Okay. Good morning, everybody. Thank you, Dr. Najat, and to the whole team for this event and for inviting me here. I want to share a little bit about my story. It's interesting. I think I'm maybe a little bit opposite to the last story in that I grew up with classic endometriosis symptoms, pain so severe that I would black out in my bathroom, just bleeding and unable to walk. And my solution to that was to take hormonal birth control consistently for about 15 years so that I didn't even have periods, because who has time for that when you're trying to build a career and build a life for yourself? That stopped when I was 32 and my husband and I wanted to get pregnant. And that's when we realized just how extensive my endometriosis was. So I do have stage 4, and I've been battling a sort of multi-systemic endometriosis over the past 3 years. I've had 6 major surgeries and a lot of minor procedures, things like kidney stents. And to be honest, at the beginning, the lung endometriosis, when we first figured that out, was perhaps the least worrisome to me, because I was in this repeated battle to try to save my reproductive organs, to save my kidneys, which Dr. Najat worked very hard to do, and we were successful. But I have a type of endometriosis that's extremely recurrent. It kept growing back, and I needed additional emergency surgeries. The first time that I realized something might be off with my lungs was actually when I did a round of in vitro fertilization. I'd had my fallopian tubes removed. They were damaged from endometriosis. And as I was going through the medications, I noticed a distinct kind of crackle and cough in my chest. And I thought, how odd. I actually wound up going to see my primary care physician about it, who didn't know what was going on. When I finally figured it out, it was a few months later when I had that same symptom, along with a high fever and a cough, which occurred right after a surgery. And so I was hospitalized, and they did a X-ray, and I was diagnosed with my first official pneumothorax. It was a small one, a small lung collapse, a small piece, which at that point was able to resolve on its own. I continued to have small kind of spontaneous pneumothoraces over the coming years. And they were manageable in that they could ultimately resolve on their own. I got to understand sort of what it felt like to have a small piece of your lung collapse, do a lot of deep breathing to get it kind of back in place. And then eventually, you know, after a lot of very severe and recurrent symptoms, I wound up having a hysterectomy. And I was thinking at the time that that might also help with the lung situation because I was on strong suppressive medication. I'd had a hysterectomy, and I felt like maybe that would also help with the lungs. I found out that that wasn't true in a pretty dramatic way. I had flown around the world to visit my husband's family, and after a very long plane trip, which I learned later can be a trigger, about 50% of my lung collapsed. And so when we returned from that trip, I had immediate surgery to fix the lung. My case, again, recurrent and a little odd, but although the surgery was very successful, they found endometriosis on the diaphragm and the lung, were able to remove those pieces and do a pleurodesis. I had additional symptoms a few months later, and even though it was pretty unlikely, we got a scan and found that it looked like the collapsing was continuing. So we did do another surgery to fix that. I will say that was the last of my surgeries. And I feel incredibly grateful to the amazing team that I've found working with Dr. Najat, Dr. Bacchus. I mean, after an extensive period of time and a ridiculous amount of pain, as many people will understand, you know, again, I feel just truly that I have my life and my health back in my hands. So.
Thank you very much, Abby, as always, for sharing your story and helping other people to understand about this enigmatic disease. And now we are going to go to Dr. Leah Bacchus, your doctor. And thank you all of you who have submitted your questions. And Dr. Bacchus is going to address all the questions that they have been submitted. Dr. Bacchus is a cardiothoracic surgeon and a specialist for malignancy, cancer, and we have been privileged to work with her, with our patient with endometriosis of the thoracic endometriosis syndrome. Leah? Unmute yourself, Leah.
Thank you, Cameron. What a really nice introduction, and thanks for the invitation to come and participate in this webinar. I am happy to answer the questions that have been already pre-submitted or any other questions that may come up in the chat. Do I need to pull up the questions or?
Yeah, go ahead and you use, yes, you have all the questions you have received.
Okay, I don't have them right this moment, although I did review them. I will pull them up. Sorry, this was not a part of the prep.
No problem. If you don't have it, this is very easy for us to bring up the question.
I've got it now.
Yeah.
Okay. So the first question has kind of already been answered, I think, very eloquently by our patients. And that question is, what are the symptoms and signs of endometriosis of the diaphragm and the lungs? I'll just try to reiterate what was already said. The main symptoms are pain or pneumothorax, which is collapse of the lung, or sometimes hemothorax. And the pain is the one that probably varies the most in that it can be, it's usually a sharp pain rather than dull pain. And you can have referred pain such that if it's specifically the diaphragm that's the most involved within the chest, then you can have, because of the way that the nerves are in proximity to one another, the perception of pain on the diaphragm is referred to the shoulder. So you can certainly have patients presenting with shoulder pain who've had extensive workups of their shoulder pain without anything being found. That can also be a symptom of endometriosis. So those are the main three: pain, lung collapse, and hemothorax. The next question was, does every patient need a thoracoscopy? I think that's a really good question. So, I mean, I think the short answer is no. But much like the abdomen or the pelvis, if you truly are trying to confirm the presence of endometriosis or not definitively so, then yes, you do need that. I think the difference though with the chest is that any patient that I'm operating on has already had at least one, if not several prior surgeries in the abdomen. And so the diaphragm is a really interesting organ, if you will, because it's a double layered muscle. And so you can have endometriosis on either the abdomen side of the diaphragm or up above on the chest side of the diaphragm. And if you see endometriosis on that abdominal side, then certainly I'm much more suspicious that there could be endometriosis on the other side. But you can have it only on one side versus the other. So if you've had a laparoscopy that confirms presence of endometriosis on the diaphragm, then that definitely, and you have chest related symptoms, then that's highly suspicious that it would be present. And those are usually the patients that I see referred from Dr. Najat. Feel free to stop me at any point here, Dr. Najat.
No, please. No, this is the podium is yours. Please answer all the questions because people are very interested and are watching. Answer all the questions, please.
Okay, great. The next question is, can you have thoracic endometriosis and not have a period? I think that's a good question. It may actually be better answered by you, Dr. Najat. I mean, you can certainly have endometriosis and it may not be, it can be somewhat quiescent. It can sort of just depend upon if you're under hormonal suppression at the time or not, whether or not you have endogenous estrogen production at the time, et cetera. So you can absolutely still have the endometriosis. Whether or not it's symptomatic is a separate issue. It just depends on where you are in your treatment of the primary endometriosis. Did you want to add anything to that at all?
Yes, I agree with Dr. Marcus. Endometriosis, as I said, it is a very enigmatic disease. Actually, we have reported one case, and not that specific case. This is part of the case series that Leah, we did it with the previous thoracic surgeon. He was at Stanford, Dr. Ramin Beigui, that she had history of hysterectomy and bilateral salpingo-oophorectomy, and she was on hormonal suppressive therapy, and she ended up having endometriosis of the lungs, and so we had to resect it. So you are correct. It could happen.
Okay. The next question is, can endometriosis be found in the nasal passages or airway? If so, what are the symptoms patients should be aware of and how is it diagnosed? I personally have never seen endometriosis in the nasal passages, so I'm unaware of that one, but within the airway, like the trachea, the bronchi, et cetera, like in the tissue of the lung, yes, you can. It's incredibly uncommon, but it's certainly a potential there. And at the time of surgery in the chest, I always do a bronchoscopy specifically to look for that. The way that it would otherwise present in a patient is that they would have blood-tinged sputum or they're coughing up blood. And again, that would be periodic, and it may not be frank blood. In fact, it probably won't be. It'll be kind of that same chocolatey sort of old blood look, that kind of rust-colored, deep brownish red, and it may or may not accompany your other endometriosis symptoms. Again, it will depend upon whether or not you're being hormonally suppressed at the time. So it's possible. It's incredibly uncommon, but it's something that I look for, which is very easy to do at the time of any chest exploration via bronchoscopy.
I agree with Dr. Marcus again, that this is very rare, but endometriosis of the mucosa of the nose has been reported, and we have seen also one case of in our own practice. So it is possible, but extremely rare.
It's one of those things that like it can be anywhere.
That's right.
As you said, very enigmatic. Let's see. The next question is, I have pelvic and thoracic endometriosis. I've had lung collapses with both lungs. I'll be 38 years old this month. Is it possible to still think about having a baby? I'm currently taking CBD and THC oil and Visan, and it helps, but I would like to have a baby. Is that still possible? I mean, I think that that's much more of a question for you, Dr. Najat.
Yes. First of all, definitely your condition is possible. I want to let everybody know, all the people who are watching, all the people who have submitted the questions, we are not treating you here. We only as a general rule, we are answering these questions. Every one of you has to be seen by a specialist to be evaluated. Everything that we say here, and we are answering your questions, we are not an advice, and it is not a treatment for you. You have to see and to be examined by us or by your physician, then we make the final decision. This is only suggestions as guidelines. But the answer to the last question, yes, definitely it is possible for you to get pregnant. And thank you. Leah, please continue.
Sure. I can jump over to the chat here. There's a question specifically for Dr. Sina and Dr. Farr, but I can also address it here too. It says, is it possible to have thoracic endometriosis and not have a lung collapse? I mean, the short answer is yes, absolutely. So you can have totally asymptomatic endometriosis in the chest to severely symptomatic and everything in between, but I'll defer to Dr. Sina.
Well, hello. Yes, these are all fantastic questions. As I mentioned, and I showed you actually one of my severe cases that it was incidental finding. You could have endometriosis without symptom specifically on the diaphragm. It depends on the location of it and how it would affect the structural abnormality. But patients could have endometriosis of the pleural, like you saw, and they don't get the lung collapse, but they could have shoulder pain, chest pain. Actually, it would bring us, if you don't mind, I can go ahead and introduce our third patient, who I am grateful for her to volunteer to share her story. Mrs. Michelle Sunquest, that you will be amazed to hear her story, and I am impressed because of the educated patients. You heard the stories of, unfortunately, due to the lack of awareness, some of the healthcare providers may underestimate the endometriosis. So Michelle was the person who educated herself, and Michelle has little Sina with her. Welcome, Michelle. I will stop talking and let the people judge for themselves that how educated patients could take control of their health.
First of all, I want to tell you, Dr. Najat, it is an extreme honor to be able to do this. I'm actually overcome with excitement and emotion. You guys, every participant out there is looking at little Sienna. I named my daughter after Najat, and this is going to be the most unbelievable story. Till this day, Sienna is 6 years old. Sienna, if you want to look up and say hi. She has been the biggest blessing. And I got on when I heard the 38-year-old talking to Dr. Bacchus about how she's 38 years old and have 2 lung collapses. Well, I'm going to tell you this, and I hope you're listening. Don't let anybody tell you it's not possible to have children, because my story was what you would consider impossible. And by the grace of God and by the hands of Dr. Najat, I have 3 biological children I'm going to tell you about. So let me share my story. Back when I was in my 20s, and actually when I started my period, I was around 12 years old. And I will never forget my first period. I was in a lot of pain. I didn't know what was going on. I am Middle Eastern, so my family was not one to really talk about these kinds of subjects. So I kind of just discovered it, and I remember the teacher had to send me home, and then my mom realized, wow, it was her period, and she can tell I was in a lot of pain. And I had had a lot of pain since that age, but managed it with Tylenol. But as I got older, got more severe. When I was in my 20s and I had just started my new job, the pain seemed to have gotten worse and worse. And the pain started to become associated with violent vomiting. But I never really put that my period and my vomiting, it didn't seem like the two would go hand in hand. So one day I had to go to the hospital. The pain was so excruciating. I vomited so much, and that's when I was admitted for surgery. I think they did a scan first and realized that I had a bowel obstruction. When the pathology came back, they noticed that I had a bowel obstruction from endometriosis. I was around 27 at the time, and I realized that, oh my goodness, that's how bad my period was. That's how bad endometriosis could be. Then shortly thereafter, I had gotten married, and my husband and I started to try to have children. And I guess in the back of my mind, I kind of knew that I was going to be in a lot of, I guess I knew it was going to be difficult just based on how much pain I was in and the surgeries that I had to go through, namely the bowel obstruction. So I had a bowel resection. Well, I decided somebody would refer me to a doctor, just from a girl that I heard, to a doctor in Atlanta. But then when I told my OBGYN here that I'm going to this doctor in Atlanta, would he give me the referral? He goes, wait a second, I'm going to refer you to somebody better. It happened to be a doctor in Atlanta. He says, no, I don't want you to see this doctor in Atlanta. I want you to see a man named Sienna Najat. And he looked at me and he said, this is the doctor that every OBGYN goes and sees. And he says, don't go to anyone else but him. He goes, I've learned under him, and all my brothers learned under him. So I was so happy. The first time I met Dr. Najat, I just loved him. My husband and I were so comfortable. And he had to do the first surgery, which was about 5.5 hours long. And he can tell you there was a lot of endometriosis. But then he gave me his blessing to go ahead and do IVF, because he says now everything is clean, all the endometriosis is off your ovaries. But he goes, I'm going to tell you, it was everywhere. It was in my uterus, my lack of a better term, my buttocks area. I mean, it was everywhere. So then my husband and I proceeded to do IVF, and I got very blessed on the first time. We had a beautiful little boy who's not here. They went to go play tennis, and that was such a blessing. And that was great. Then I wanted another child, obviously. And the older I got, the harder it became. But I went every time I did an IVF. So I had done like 5 IVFs, and I kept failing after I had my son, Jack. And of course, what did I have to do? It was time to go see Dr. Najat, the one and only human being that I trusted with my body. And let me say this again, these men are literally the best of the best. I will put my hand on the Bible and swear to it. Then again, Dr. Najat, when I wanted my second child, did my second surgery. And everybody used to say, well, you shouldn't have any more endometriosis after you have had your first child. Well, I know now that is not true. He did his endoscopic surgery. And, I'm sorry, I'm not telling you the full story. Between my first son and my second son, Evan, I had 12 failed IVFs. And when I went back to do a second procedure, 12 failed IVFs. When I went back, lo and behold, when Dr. Najat goes in, cleans me out, I had my second child. None of the reproductive oncologists could believe I had a second biological child, because let me tell you, that follicle stimulating hormone test kept saying I have no eggs in my ovaries. But I'm about to tell you the most unbelievable part of this story. I really wanted a little girl. I wanted a girl more than anything. And I begged and begged my husband to please, let's go through this one more time. Now, I am not going to lie to you. I hated IVF. By the 14th round, my body is just so fatigued from these forced hormones. And I almost didn't want to do that. But I went to have one more surgery with Dr. Najat. And these were his last words to me. And these words will forever be cemented in my head. He goes, Michelle, I got a woman naturally pregnant at age 47, and I have C in your ovaries. There are eggs still in your ovaries, and I don't see any reason why you can't have another child. Well, anyway, we go back, and I decided, hey, I'm just gonna do everything as holistically as possible, along with the IVF, but in the meantime, I'm still gonna try, you know, to get my cycles right, and I was working with a doctor in California. And then finally, you know, I just ate better, listened to the advice of my acupuncturist. And on the day that the IVF medicines arrived for the last and final round, because if it failed, then I'm out of luck. This was it for me. I was feeling really sick. I mean, my husband was making hamburgers, and I was like, this is just terrible. And he goes, Michelle, just take a pregnancy test just to see. I said, you know, it's going to be negative. I was like, let's not even waste our time. Well, he just goes out and buys one. No, I'm sorry. We happened to have one at home. And I said, just go ahead and tell me it's nothing. He goes, it must not be working because it says pregnant. It's flashing pregnant. I was like, what? Yeah, he said he thought it was broken. So of course we were shaking. He ran to Walgreens and bought 5 more tests. Pregnant, 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 and with 5 weeks plus. Of course, I called my acupuncturist. I called the doctor, and the doctor says, come and let's see. The next day, there it was in my uterus, a beating heart, a little tiny beating heart. You guys have to understand, every doctor said I could never conceive naturally except for Dr. Najat. Even though Dr. Najat was very supportive with IVF, I hanged on so dearly to those words. It was the day that the 14th box of in vitro medicines came, and there I was carrying a little baby. So I go to the maternal medicine. I had to get a maternal fetal because I was considered a senior citizen. I think I was 39 years old. And they kept saying, do you want to know what it is? And I'm crying. I'm like, oh, I just don't want God to think I'm ungrateful. Maybe I shouldn't know. I shouldn't know what it is because God has already blessed me with 2 beautiful children. And the lady kept saying to me, are you sure you don't want to know what it is? I'm like, but I was so engulfed in my emotions. I didn't realize what she was trying to say. And I guess my husband looked at me and said, for God's sakes, let's just find out. I think I was at this time 20 weeks and we opened up the results and there it was, a little girl. I went crazy. I even fell on my knees. I called Dr. Najat immediately. But before I called him, I wanted to look at the meaning of his name. I pulled it up on my phone and it came up, Sienna, C-E-A-N-A, came up. The meaning was God is gracious. And I called Dr. Najat and I said, Dr. Najat, we are having a girl. I got pregnant naturally and I'm naming this child in honor of you. And today, Sienna, look up and say hi. Hi. This child, this miracle baby, when every doctor except for Dr. Najat, who so believed in me, believed in my cause, allowed me to have this child. When I went to the reproductive endocrinologist who told me that I'll never have my own child, he could not say anything. He threw up his papers in the air and said, it just goes to show God is the ultimate and he's in control. And I'm here to tell you, make an appointment with one of these Najat brothers, or it's Dr. Leah, because I'm telling you, it is worth going to the best of the best. And my endometriosis didn't stop after my daughter. For the person on the phone who had the lung collapse, this lovely 38-year-old, well, after Sienna, when Sienna was a year old, my endometriosis came back with such a vengeance. I ended up having 4 lung collapses, 4. And when I was in the hospital with the first one, and I called Dr. Najat, as I always do, he said, you know what? I bet it has to do with your endometriosis. I'm sitting here today pretty free of my endometriosis because I've done everything Dr. Najat told me to do. Yes, I had my 3 children. Yes, I had to go into early menopause, but I would do it again. I would absolutely see one of the Najat brothers. I would say listen intently to their advice, because I am sitting here with 3 miracles and I'm a firm believer. And anybody is free to reach out to me because my story is unbelievable. And I'm happy to say it is possible. It is very possible. Thank you.
Thank you very, very much, Michelle, and also beautiful, beautiful Sienna for joining. And the Sienna looks fantastic, and also she looks awesome because of the Halloween.
Yeah.
I really like your Halloween costume. And thank you for sharing your very, very wonderful, inspiring story and raising awareness about this. We truly, truly appreciate your kindness, and we congratulate you and Sienna, also my brother, to be part of your life. And congratulations.
Thanks.
So
Can I briefly add one more thing that Michelle, after 3 long collapses she had, one of the audience had asked that could you have long collapse without long endometriosis? Yeah, Michelle did. And she had to do she had diaphragmatic fenestration that we took care of it. And I am pleased to tell you, since her last surgery, thank God she's been symptom free. Am I correct?
I have been the happiest I've ever been, completely symptom free, like a new person. Yes, I am the happiest. This is why I want to tell your people, don't go shopping around for doctors. You're seeing the best here on the panel. It's worth flying out. I had to travel almost 4 hours every time to see them. I don't regret it for 1 minute.
Thank you very much, Michelle. Thank you, Sienna, for joining us. Happy Halloweens.
Yeah, bye.
Bye.
Well, thank you very much again, Michelle and Sienna, and also our other panel. What we have to say is, I want to say again, all the physicians, all the doctors are very good. They have good intentions. They want to help. The issue is the problem with endometriosis, which is enigmatic. That is why the purpose of this series is to raise awareness among everyone, and thank goodness we are making progress. We want to mention to you that we thank you very, very much for joining us. You will not be having, or we are not going to be having any sessions for the remainder of the year. That means for the November and December. We wish you a safe and happy holiday season. Join us in January, where we will kick off the year with a session on endometriosis on teenagers. And the reason that because of the November and December is going to be holiday season, everybody is going to be busy. You can continue to see the previous webinars if you would like, and visit them on endometriosis or EndoMarch, www.endomarch.org. If you go there and click on the webinars at the top, then you can see the previous session. What we are doing here is we are not telling you any medical advice, except that you have to see a physician who's an expert, and then they would give you opinion. See any physician who's an endometriosis expert. If you are around Atlanta, New York, or here, we would be happy to see you. And it would be a pleasure. We would like to thank all of the participants, especially Dr. Parkers, Michelle, Abby, Jessica, Dr. Jackman, and Dr. Agrawal, who have been online, our fellows who have been answering questions, Barbara Page, Zoe Pennington, Tiffany Letowski, Sean Stetner, and Lily Cooper. You all have been fantastic, have been great. Wishing you a great holiday season, and we will see you in January. Bye-bye.
Cameron, do you mind? One question somebody asked on the chat, I answer. Just quick question.
Please go ahead, please.
I am sorry, because I don't want to not answering this question. There's a question that this patient had vast and had endometriosis, was not removed, and she had pleurodesis. Can she have another vast and take care of endometriosis? Because she was told it is dangerous. And the answer is yes, she could have another vast. As I showed you in my video, this patient had vast and pleurodesis before. It is more difficult, but it can be done by expert. Thank you.
No, that is a very, thank you very much, Dr. Parnijat, for bringing up. That is why in our positions, when we see patients who have endometriosis of the lung or diaphragm, we don't do pleurodesis regularly, because when we see the pathology, and endometriosis is recurrent, we only remove the lesion, and doing the pleurodesis sometimes makes it more difficult to do another VATS, so or thoracoscopy. So that is why we, in our presentation recommendations, when we see definite endometriosis, we excise it, we remove it, and we do. Thank you so much, Dr. Parnijat, for bringing up this question. Anyway, Dr. Bacchus, Dr. Sinanejad, do you have any recommendations? Any of the other panel? Michelle, Jessica, Abby, do you want to say something? Anybody has anything to say?
Michelle, you are mute.
Unmute. Okay. I just want to, let me just reemphasize this again. Every doctor I had seen prior to Dr. Najat said it was impossible. They even encouraged me to go for donor eggs. Please, it is worth the travel. It is worth the headache. It is worth the money to go see the best of the best. And you know, don't sit back and say, I can't have children. Well, I can honestly tell you, you can help children. These doctors are incredible. And if it can happen to me, it can happen for you.
Thank you very, very much, Michelle. You are so kind. And I tell you, I cannot get over how beautiful is Sienna. And look, contrast to it is my brother. Look, Sienna. Beautiful Sienna, and look at my brother. You cannot even look at him.
Thank you, Michelle. Thank you, everybody. But to re-emphasize what Dr. Farnejad, Michelle also had pleurodesis before, which shouldn't have been done. And we did, when we did her VATS and took care of the fenestration, took care of her problem. And Michelle has given me permission to share the story. So Michelle is a perfect example of a patient being her own advocate. And when they told her, oh, we did pleurodesis, you shouldn't get it, she said, no, I'm going to go see Dr. Najat. We took care of her. So it can be done. Thank you again.
I agree. Michelle, Leah, do you have any last minute suggestions, or would you like to say anything? Dr. Bacchus?
If anybody wants to call me, please give them my number. I love to help people. I want to help them. I want them to believe. So you feel free to give them my telephone number.
Thank you so much, Michelle. Thank you so much. Thank you. Sienna, I like your little costume.
she's a Finnegan fox.
Yeah, it looks beautiful.
Thank you.
So, Dr. Bacchus, do you have any last minute additions? Would you like to say anything?
No, not really. I mean, I think that the stories are the most compelling thing, that the strength of this whole webinar has been the impact of having the patients themselves describe their journeys. Everyone that I've ever encountered has had a very lengthy journey. It's not just a one and done kind of thing. And so I think it's I mean, not being an endometriosis patient, I still think that these stories are incredibly impactful. So it's really nice of you all to have availed yourself and recognize the fact that it is a journey for sure, but that if you've got the right team working for you, that there should be some light at the end of that tunnel for sure.
Thank you very much. Thank you, Dr. Azadeh-Nejad. If you are online, do you have anything to add about the patients or patient that you see with endometriosis of the diaphragm and lung?
Yeah, I just want to say, first of all, I apologize. I didn't get to introduce our wonderful patients, Abby and Jessica. No, I think it was a fantastic webinar, and everybody is, we're so excited to see them doing a lot better than they were doing. And all of them, they've had a really tough journey, but the end result is wonderful. So we're happy they have had great results.
Thank you very much. Thank you very much. Anybody else has anything? If you don't, we again, one more time, we say goodbye and happy holidays to all of you.
Bye. Say bye.
Bye-bye. So I will proceed first with Dr. Zondervan. She is Professor of Reproductive and Genomic Epidemiology at Oxford University and head of the Neufeld Department of Women's and Reproductive Health. She is co-director of Oxford Endometriosis Clinic. And Dr. Zondervan is one of the most highly cited authors in reproductive sciences. And in 2013, she was recognized as an outstanding female scientist. She's in Oxford, England. We thank her very much for staying up late. And we welcome her. And please go ahead. Go ahead, please, Karina.
Thank you so much, Dr. Najat, for that really kind introduction. And I'm absolutely delighted to be able to speak with you all today. So I thought I'd first start by telling you all a little bit about me and how I came to research endometriosis, which is a journey that started more than 25 years ago now. I am an epidemiologist originally from the Netherlands, where I trained first in biomedical sciences and then in epidemiology. And I came to Oxford as a student back in the early 1990s. And during my studies, I had developed an interest in women's health and epidemiology, which I felt was an area that was very understudied. So that really led me to want to work in that area. As you know, some of you may know, epidemiology is a field of research that studies the prevalence or the frequency of health conditions and also risk factors for those conditions using very large scale data-driven studies. And the aims of such epidemiological studies are to shed light on the burden of diseases from a public health perspective and to find factors that are linked to their causation. And a famous example of a link that was made in using epidemiological studies is one that we all know about, which is a link between smoking and lung cancer, for example. So, you know, having always loved mathematics and data analysis, the field of epidemiology always appealed to me, but I really wanted to apply those techniques to women's health. So when I first came to Oxford from the University of Leiden in the Netherlands, I started a PhD in public health and obstetrics and gynecology, working at the time with doctors Stephen Kennedy and David Barlow. And my PhD involved the mapping of prevalence and risk factors for chronic pelvic pain in women in the UK, because there were no robust data at all about how common pelvic pain was in women in the UK in particular, and there are actually very few data worldwide on this topic. And these studies show that chronic pelvic pain was extremely common, affecting 15 to 20% of women, but also that many of these women had these pain symptoms for many, many years before receiving a diagnosis, as I'm sure you are well aware of from your own personal experiences. So, and because of my own biomedical background, I was intrigued that a common diagnosis was endometriosis, which was a common that actually very few people around me that I spoke to had heard of, and that we knew very little about in terms of its causes. So I decided that after my PhD for my postdoctoral research, I really wanted to study endometriosis to help shed light on the impact that this condition had globally on women and to better understand risk factors and causes for the disease. So first of all, together with the World Endometriosis Research Foundation, I led a study investigating the impact of endometriosis globally, in which one of my first PhD students, Kelechi Noaham, at the time analysed data from women first undergoing surgery for endometriosis in 10 countries across 5 continents, really. It's a very large study. And these data showed a remarkable consistency in the experience of women impacted by endometriosis. I mean, on average, there was a delay of diagnosis between first onset of symptoms and diagnosis of about 7 years. And that delay mainly related to the time it took for women to be referred from a general primary care physician on to a gynecologist and a specialist in endometriosis. And it also showed that endometriosis had a huge impact on the lives of women and their families, both in terms of daily lives, but also the effect on work, with an average of 11 hours a week lost due to endometriosis that we sort of calculated from these studies. And this was really a study that was very close to my heart because it raised a lot of interest, and I got a lot of questions about, what is endometriosis and how can we research this further. And it was a study that ended up being highly cited and was amongst a sort of 25 historic papers published in Fertility and Sterility at the 75th anniversary of the American Society for Reproductive Medicine. But I mean, as I mentioned, that is work on impact and on prevalence, and it's hugely important. But I also really wanted to work on understanding causes and risk factors for endometriosis. And one of the aspects that intrigued me with my background in biomedical sciences was that endometriosis has a very strong heritable component. In other words, endometriosis can run in families. It doesn't always do, but it can do. And my PhD supervisor at the time, Dr. Stephen Kennedy, had started collecting DNA and data from women with a family history of endometriosis in the 1990s and had led analyses investigating these families. And what I wanted to do is follow on from that work by starting large-scale studies into endometriosis, not just focusing on families with a strong family history, but also looking at genetics of endometriosis in the wider population of women. And I really hoped by understanding which genes and which DNA variants in these genes are involved in the development of endometriosis, that would tell us more about the biological causes, but also about potential subtypes of disease. This knowledge would then hopefully lead to new ways of diagnosis and new medical treatments potentially. So with that sort of vision in mind, I ended up getting some fellowships from the Medical Research Council here in the UK and a Wellcome Trust, and started my own group focused on endometriosis research back in 2007. And together with Dr. Christian Becker, a gynecologist in Oxford, I co-founded the Oxford Endometriosis Care Centre in 2012. And we've worked together ever since, and building the research arm of the centre to around 25 staff and students now. So studying genetics of any disease means you have to, and genetic epidemiology, you have to study large amounts of data. And that was very apparent from other such studies that were successfully carried out for other diseases with a large public health impact. And you can think of diabetes, cardiovascular disease, cancer, and we learned a lot from that. And one key aspect that we realized quite quickly was that this required collaboration between groups. And it's been a huge privilege to work with wonderful clinicians and scientists across the globe to understand the genetics of endometriosis better. And that includes the other panelists here on the call, which I'm very excited to join together with. So, but even more importantly, it relied so heavily on the willingness of women with endometriosis to participate in the research studies, and I cannot tell you how grateful and impressed I am with the dedication, and the rest of my team, with the dedication we've witnessed, and the enthusiasm with which women have participated in the studies and those of our collaborators. And it's been a true source of inspiration for me personally as well. I just wanted to really highlight that. So you will probably ask, where have we come to in understanding these genes or gene variants that are associated with endometriosis? Well, we've just submitted for publication the results of the largest collaborative genetic study to date, involving DNA analysis from more than 60,000 women with endometriosis and more than 700,000 of women without endometriosis as a comparison. And these data were derived from 25 data sets and centers across the globe, contributed within a research consortium, the International Endometriosis Genome Consortium. So we found 42 genetic risk variants for endometriosis, 31 of which we had not known about before. And we also showed that ASRM stage 3-4 disease appeared to be really quite different in terms of its genetics than stage 1-2 disease. And work that Dr. Mismer and her group did subsequently show that the effect of these risk variants seemed to be different between ovarian endometrioma and superficial lesions. In other words, these seem to be regulated differently genetically. And this has started further work on subtyping endometriosis that I know Dr. Mismer will touch upon later as well. Now, knowing which DNA variants increase the risk of endometriosis does not necessarily tell us which genes are affected by these variants. And this is quite a complex area. We need to ask the question, which genes are affected in their expression by these variants in the tissues that are relevant to endometriosis. And the tissue that is clearly most relevant to the endometriosis is the endometrium. So as part of our recent consortium study with collaborators, Dr. Montgomery and his team in Brisbane, we studied the effect of these DNA variants on gene expression in endometrium and also in blood, using different data sets that our groups had available. And that led for the first time to a strong list of genes that we know are affected by these variants. And many of these genes are involved in hormonal regulation, but also inflammatory response and cell growth. And our follow-on studies that we are doing now, we can now use these gene lists to identify potential new targets for medication development that could be designed. And of course, in particular, we are interested in genes that impact non-hormonal biological pathways, in particular inflammation. And just as a very brief example of that, we've just published a paper in Science Translational Medicine that really showed the power of genetics in this. In this time, we used data from family-based studies, and we identified a gene called MPSL1 associated with endometriosis. Now, MPSL1 was a really interesting gene because it also had been associated with other inflammatory conditions, asthma, inflammatory bowel disease, rheumatoid arthritis. And we then worked with other academic groups and industry collaborators to block MPSL1 in both cell assays and in other models. And look at the effect. And what we saw was a reduced amount of inflammation and a reduced amount of pain. So although we need to do a lot more follow-on work on this to understand the mechanisms involved, we were really quite excited by the potential of this particular target to be a non-hormonal target we can work with as we move on. Now, then as a final point I would like to make, I'd like to come back to my earlier point of the need of large-scale data. And of course, as an epidemiologist, I would say this, but it's so crucial to our work. And we've been collaborating with Dr. Mismer for many years on sharing data. And quite early on, we became aware that in order for us to collaborate effectively, we needed to collect the same data and collect all our samples using the same protocols. Otherwise, if we can't replicate each other's findings, we don't know whether that is because then they're false or whether we're just not comparing the same data. So Dr. Mismer, together with Christian Becker and I, founded the Worth Endometriosis Phenome Biobanking Harmonization Project, or EFECT for short. You can look this up online if you like, but that really is the culmination of 30 centers that are participating to come up to a consensus for data and sample protocols for sample collection. And now there's these were freely published online, and anyone can use this. Any research center worldwide can use this. And there's now 50 such research centres using these tools worldwide, and they have already led to new funding to fund research into endometriosis, also in studies sort of led by Dr. Jadis and Dr. Misma here on the call. So I think that's where I should stop now. I hope that's given you a very brief flavour of some of the work that I'm passionate about, and you know, I will spend, you know, the rest of my working career certainly working on, and to say also many thanks to our collaborators in working with us on this, and thank you to you for your interest.
But I have daughters at home, I have, you know, nieces at home who have similar symptoms to what I have. I mean, we literally had 2 patients just yesterday. So do you think that these women and girls, when they come in, they can be screened for genetic variants that can predispose them to endometriosis?
I think it's a really excellent question, and as you mentioned, it's one that we often, you know, hear, and unfortunately, I would have to say at this point in time we can't use that knowledge that we have for that particular purpose, and the reason is because the genetic variants we have identified, each of those increase the risk of endometriosis only by a very small amount. So if you add up sort of the whole sort of panel of 42 variants that we now have, that only explains about 5% of disease risk. And as you can imagine, you know, sort of putting together a test on the basis of that would really not be, you know, very helpful to women, you know, for screening purposes. So I think that the value for genetics currently is for us to understand the biology of the condition, and to identify subtypes of disease, and to try and identify new targets for the development of medical treatments that actually target those subtypes specifically. That's the vision that we have, but unfortunately they don't have use as a clinical screening tool at present.
I see. Do you think that will ever happen, where we'll ever have it to where we can just screen people and be like, you have endo or you don't?
So I think on the basis of genetics, it's unlikely. And part of the answer is as the statistics that Dr. Jadis already mentioned, you know, only about 50% of endometriosis risk is genetic. The other 50% is environmental, and that's to do with factors that are, you know, that either predispose or potentially protect to develop endometriosis. So that's one. So only about 50% we know is genetic. Actually identifying all those variants that contribute to that 50% is a very, very difficult task indeed, and is almost impossible. And we know that from other disease areas. I mean, for example, if we look at a field like breast cancer, currently they're now nudging up to, you know, understanding perhaps about a quarter of genetic risk, and they're starting to think about, you know, can you know, tools that combine genetic risk variants combined with known environmental exposure, you know, risk assessment, family history, all together, can that be developed into a tool that is useful for screening? But I think even then, the question is, well, the answer probably is it's a screening tool. It will never be a diagnostic tool. So I think we need to look at other ways of diagnosing endometriosis. For
right.
There are a couple of genes in breast cancer, at least, that have a huge effect size. We don't think we're going to see that in endometriosis.
Well, yeah,
right.
Familial breast cancer, certainly. Familial breast cancer, but non-familial breast cancer, you know, the genetics of that it looks just the same as it does for endometriosis. So you're absolutely right.
Wow.
Yeah.
That's amazing. Do you think your project with EFFECT will one day be able to achieve this? Like, try to find out the environmental versus genetic factors for endometriosis? Is that the final goal of having the standardized data?
So I think what we're hoping is that, you know, if many research centres collect data the same way and collect samples the same way, we'll start to be able to leverage the power of those studies jointly and start teasing out these environmental factors that Dr. Giudice also mentioned, and Dr. Mismer, and because we need the sample sizes to tease some of these effects out. So yeah, that's the hope.
Perfect. Thank you so much.
To the East Coast of United States, to Yale University, to Dr. Hugh Taylor. Hugh has been an outstanding researcher and interested in endometriosis. He is the chair of the department of the OBGYN and professor of the Anita O'Keefe Young Professor of Women's Health. And he is the past president of American Society of Reproductive Medicine. He has been devoted to research and treatment of endometriosis and trying to find out what is going on, how can we help the patient, and it's a pleasure and honor to have him. Hugh, please proceed.
Thank you so much. And I first want to just start out by thanking Dr. Najat for organizing this, for founding EndoMarch, for bringing all the awareness that is so needed to this disease. Awareness, access are so important for patients with endometriosis. So thank you for helping raise awareness, and this EndoMarch has been a tremendous asset to the field. So thank you for that, and among all your other contributions to the field, but particularly today, thank you for EndoMarch. So I started out as a physician and scientist interested in doing research to help improve healthcare. And I started out actually working on uterine biology. And I was interested in the endometrium and how embryos implant and pregnancy. But it was the patients that brought me to endometriosis. Working with patients in gynecology and reproductive endocrinology, I found that patients with the endometriosis were the probably least understood. This is perhaps the least understood disease that we treat. And the stories of patients not getting the correct diagnosis, being dismissed, could sometimes bring me to tears, were always frustrating, sometimes got me just plain angry. I couldn't see myself working on anything other than endometriosis. And since that time, I devoted my career to this. And again, it was all driven by the patients I worked with and hearing their stories and wanting to make a difference and improve that. So we've spent a lot of time working in my group on understanding the cellular and molecular mechanisms using laboratory-based models and animal models to better understand this disease. So a little different approach than you heard from our last speaker, but takes many different approaches to get to the bottom of a disease and move things forward. Our results have helped us to understand what drives endometriosis, what makes it grow, and potentially even come up with some novel treatments. Over the last few years in particular, I've been most interested in all the effects of endometriosis outside the pelvis. It was more obvious that endometriosis in the pelvis can cause pelvic pain, but we all know that that's just the tip of the iceberg. Endometriosis can occur in areas outside of the pelvis, in the lungs, the brain, many other places, not commonly, but it does. We've all seen that. Women with endometriosis have all sorts of other effects due to the disease. They have a lower BMI on average, they're lower weight. There's a generalized inflammation, as we heard about before from our last speakers, identifying some of the genes that are driving that inflammation with association with autoimmune conditions. There's an immune component to this disease. There's an effect on the brain. There have been associations with anxiety, depression, pain sensitivity. And so we've used our in vitro, laboratory-based models and animal models to really get at the cause of these things. We did some studies where we create endometriosis in mice, and we can really get cause and effect. When you see an association in women that women with endometriosis are more likely to have anxiety, well, did endometriosis cause the anxiety, or did anxiety lead to more recognition of the endometriosis? And our animal models have been really able to get at cause and effect. For example, we create endometriosis in a mouse, and the mice don't gain as much weight. We know women with endometriosis have a lower BMI, they have lower weight, lower body fat. And I've seen it in many textbooks say being thin is a risk factor for getting endometriosis. No, in our model, we proved it's just the other way around. The disease itself will cause weight loss. And we show effect on the liver. We show an effect on adipose, the fat cells. And we show how these cells are changed in a way that would make one lose weight. Endometriosis has a metabolic effect. Your metabolism is different if you have endometriosis that leads towards weight loss. So again, it's not just an effect in the pelvis. The whole metabolism is different. We create endometriosis in mice, and we see whole body inflammation. We see propensity to immune disease, even autoimmune disease in our animal models. So again, endometriosis causes these whole body systemic inflammation that explains some of the conditions that we see in women that are far too often dismissed or thought to be unrelated. We know women with endometriosis take years to get an accurate diagnosis, are often misdiagnosed. And I think because of all these different effects on other organ systems, it often leads us to follow these red herrings. You have some sort of inflammatory condition that distracts healthcare providers sometimes from looking at the real diagnosis of endometriosis. It's important we understand the bigger picture so that we're not misled and we understand the totality of the disease. We really understand everything that our patients are going through. Again, we know that women with endometriosis are more sensitive to painful stimuli. They're more likely to have anxiety and depression. And again, I get, one of the things that makes me angry is when I hear people say, and you've probably all heard it, oh, these are patients are just more sensitive to pain and they're anxious. It's all in their head. We've all heard endometriosis patients dismissed and insulted. And our work in the mouse model shows that when we create endometriosis, it changes the brain. We can see changes in genes in the brain. We can see changes in the electrical connections in the brain. And the mice develop anxiety, depression, and increased pain sensitization. So anxiety and depression are a direct result of endometriosis. We know the endometriosis causes this. It changes, it reprograms the brain. Again, it's not just about what we see in the pelvis. Endometriosis has these broad effects on the whole body and explains what our patients are going through. And we know the endometriosis causes that pain sensitization. It causes the anxiety and depression. So the animal models and the molecular understanding can really be very helpful at understanding what our patients are going through to help us not dismiss these other symptoms as irrelevant and to help us focus our diagnosis on endometriosis when somebody may have a broad range of symptoms. It's still all typically endometriosis. We've also looked at some of the mechanisms. We really want to get at the molecular mechanisms that drive these long range effects so we can help understand them, diagnose, and treat them. Maybe some of the long range effects might be better treated with different treatments than treat the primary lesions in the pelvis. We can remove those surgically or we can treat them medically, but some of these long range effects, how do we revert the remodeling of the brain? How do we revert the inflammation? How do we reverse those metabolic changes in the liver and the adipose cells? So we wanted to get at the mechanisms, and our group over the last 10, 15 years have shown a role for stem cells in endometriosis, that stem cells coming from bone marrow and other places, or stem cells directly from the endometriosis themselves can travel through the bloodstream and lead to endometriosis in remote areas in the body which they can't get to through retrograde menstruation. We've again worked on drivers of inflammation in endometriosis, and we think some of those may be very good targets for treatment to get rid of some of the whole body systemic inflammation and autoimmune conditions that plague women with endometriosis. And finally, we've looked at microRNAs. These are small RNA molecules that can be made by endometriosis, but enter the bloodstream and can have effects very far from where they're produced. We know that some of these microRNAs go to the liver and help cause some of those metabolic changes. go to the fat cells and help cause some of those metabolic changes. Go to the brain and start to reprogram gene expression of the brain. So maybe by altering some of these microRNAs, we can reverse some of these long-range systemic effects. Also, with differences in these circulating microRNAs, we note in endometriosis, we also think that they may be a good diagnostic. We may be able to start to use those differences from circulating microRNAs that we can detect in the blood to tell if someone has endometriosis when the diagnosis is uncertain, or maybe lead to earlier detection, or when someone's being dismissed and you know you have endometriosis. If we could get a definitive blood test to tell when somebody had endometriosis before we go to surgery, then decide after that whether medication or surgery is the right treatment. But if we could just detect it early, we certainly could clarify that decision. There are a lot of people who, especially non-gynecologists, who aren't very familiar or aware of the disease. So raising awareness is critical. And what we're doing here today, raising awareness, is very critical. But if those people who don't know how to diagnose endometriosis, weren't familiar with it, would have an easy blood test and then could refer them to the specialist in endometriosis, I think that would do a lot to move this field forward and shorten that tremendous delay of 10 years or so between when someone has classic endometriosis symptoms and when they actually get an accurate diagnosis. So I'm very passionate about this disease. We've done a lot in the laboratory, I think, to understand it better. It's always been frustrating to know about all these whole body symptoms of endometriosis, but I think we're starting to understand how and why they happen. And I think that will help us treat the whole patient, not just the lesions in the pelvis. So thank you, Dr. Nejat, for all you've done. Thank you for inviting me here today, and look forward to hearing from the rest of our speakers.
Thank you very much, Dr. Taylor, for your outstanding presentation. Congratulations for your outstanding work. It is fascinating, and you opened up many eyes today with what you do, and we really are grateful for and all the patients with endometriosis owe you a lot, and thank you.
I just add something to that. I'd really like to emphasize what Stacy said, is that we don't have any evidence that vaccine is harming anyone. There's good evidence now that it's not compromising future fertility. And I just want to make it very clear to everyone that we encourage you to get the vaccine. Certainly the risk of infection is clear. As Dr. Misper just pointed out, there may be some increased risk for long-term complications if women with endometriosis get this disease. So getting the vaccine is the right thing to do.
Absolutely.
Everyone should get their vaccine. The risks are even higher in pregnancy. And if you're infected and can't get your endometriosis care that you need, that could further compromise your condition. So I just want to make a clear plea to everyone to get vaccinated.
Is how are we choosing between the hormonal treatments, oral contraceptive pills versus the GnRH antagonist, and where are you going to choose between these two? And also, one of our attendees asked if we think that the hormonal treatments are only going to control the symptoms versus preventing endometriosis from progression, and is there any data and research on that?
Well, let me take that. I think there were several questions there. Let me start with progestins versus GnRH antagonists. I generally start with a birth control pill, an oral contraceptive, and tend to use it continuously rather than cyclically. But as Dr. Jadis pointed out, and was one of the first to identify the progestin resistance, it's the progestin, the birth control pill, that has the therapeutic effect, and a good percentage, probably up to a third of patients with endometriosis will have or develop progestin resistance and need to go on to a second-line therapy. In the old days, that was cumbersome with the GnRH agonists, the injectables, and the delayed onset of action and the profound suppression. With the GnRH antagonists now, it's a lot easier with an oral medication. Although there may be progestin resistance, endometriosis is always estrogen dependent, and reducing estrogen or eliminating estrogen can treat most endometriosis. But there's always a role for surgical therapy as well. Removing the lesions is a rapid way to treat this. Removing lesions can help improve fertility. Removing scar tissue, adhesions, no medication will do that. So they're disease that, not because it's resistant to estrogen deprivation, but because it's done damage and caused fibrosis, scarring, adhesions that will never be treated by any medication, that will need surgical therapy. So it takes an endometriosis expert. It's a subtle distinction as to what's treated by what means. But even after surgical therapy, I think medical therapy is a good idea to prevent recurrence and to help alleviate some of these systemic effects. My hope is that as we define these systemic effects better, that we define the mechanisms by which endometriosis causes effects on brain, on immune system, on metabolism, we might be able to specifically target those in ways that are non-hormonal, that may have fewer side effects. And that's something we're working on right now in the laboratory, that might be able to specifically target those systemic effects rather than this blanket approach with hormonal therapy. But for now, I usually would still start with an oral contraceptive. They're easy and inexpensive, and for a good number of patients, they're very effective. But always keep a close eye on my patients. I don't let anybody go for months without bringing them back to see if they're failing on an oral contraceptive. I think that's important. It's not the kind of drug you prescribe a progestin and say, come back in a year. Let's see how you do. You know that a large number of these patients will be resistant to progestin, and you need to bring them back for close follow-up and be clear that you can advance therapy to, I would recommend either a GnRH antagonist or surgical therapy if progestins fail.
Hugh, do you want to lean into that one a bit as well?
And there is some association with some adverse pregnancy outcomes, but these are rare. I would not call an endometriosis pregnancy a high-risk pregnancy per se. A slightly higher risk of some pregnancy complications such as preeclampsia, but it's still unusual and I would not consider someone with endometriosis becomes pregnant at high risk.
Absolutely.
Would you please share on what do you think is the plan of WHO, World Health Organization, for increasing awareness about endometriosis? What do they want to do? Can you share?
It was wonderful to see WHO put on a panel at the ASR meeting. We're very, very pleased that it's getting that sort of international recognition to increase awareness, to increase access. I think that's where it starts. This is a worldwide problem. It's not just here in the United States that awareness is inadequate everywhere around the world, and access is even worse in many places than in the United States. It's not good enough here by any stretch of the imagination, but you can only imagine what it's like in other places. So the attention brought to this by WHO, I am so thrilled that they are recognizing it and helping to increase awareness. Wonderful that they presented at ASRM.
Hello everybody, wherever you are. I was asked by Professor Nejat to speak about obstetrical complications in patients with endometriosis. And I was very honored because I know the Nejat brothers for many years. I read the publications already about 40 years ago, and I learned a lot from them. And so therefore I'm happy to speak about this topic. No conflict of interest. These are my disclosures. Now, the World Health Organization tells us that endometriosis affects 10% of reproductive age women and girls globally. It's a chronic disease associated with severe life-impacting pain during periods, sexual intercourse, bowel movements, etc. Endometriosis is a condition where a functioning gland and stroma of endometrium is in other sites than the uterine endometrium, leading to formation of painful lesions and adhesions. Well, why? Or what is the pathogenesis? Retrograde menstruation, coelomic metaplasia, persistence of residual embryonic cells of Wolffian Müllerian duct may develop into endometriotic lesions, in response to estrogen, dissemination by lymphatic hematogenous vessel, endometrial hematopoietic stem cells could differentiate into endometriotic tissue at different anatomical sites. Hormonal, neurological, immunological factors are all implicated in the mechanism contributing to development of symptoms because definite diagnosis requires surgery. This is often a very long diagnostic delay after onset of symptoms, and sometimes I said to myself, mea culpa, it took me too long until I decided to do a laparoscopic diagnostic, laparoscopic procedure to find out that the woman had endometriosis. And sometimes I feel like in this drawing of Escher that we are going and going and going, but we are staying at the same place. So all of us knows that sometimes very small, minor findings are causing severe pains, like here, and sometimes disseminated endometriosis are nearly with no symptoms. It is uncertain whether laparoscopic surgery reduces overall pain associated with minimal to severe endometriosis. This is also my own experience. And the complications of endometriosis includes rupture of endometriomata, infertility, loss of pregnancies, and obstetrical complications. Now, sometimes women have difficulties to get pregnant for many reasons: distortion, blockage of reproductive organs, decreased egg quality, sometimes if you have endometriomata in the ovary, general inflammation, or embryo implantation problems. Here you can see a case, a woman with severe adhesions. She became pregnant probably after these were removed. Obstetrical complications associated with endometriosis, according to our experience, my own experience also, usually women with endometriosis will have normal pregnancies and deliveries. Some might have complications, miscarriage, toxemia, premature deliveries, placental complications. Miscarriage. Women with endometriosis may have a higher risk of miscarriage compared to those without it. The underlying mechanisms are not fully understood, but factors like inflammation, hormonal imbalances, and compromised uterine environment are believed to play a role. If we compare spontaneous pregnant patients with endometriosis to disease-free women, miscarriage rate was higher in the endometriosis group, and endometriosis appears to be a risk factor for miscarriage. Ectopic pregnancy. Once in a while, we see a case of endometriosis with ectopic pregnancy, may contribute to the development of ectopic pregnancies. The presence of endometrial tissue in abnormal locations in the tube, for example, may disrupt the normal implantation process. Proliferation of reflux endometrial tissue arrested within the fallopian tube could provide the epithelial characteristics of a uterine environment, misleading, and then the implantation will be in the tube. Possible evidence of association between endometriosis and ectopic pregnancy was observed. However, these results could be considered with caution, owing to high heterogeneity among studies. And here I would like to stress again, we worked a lot about the importance of standardization to compare short and long-term outcomes among different surgeons, institutions, and countries. Only standardized surgical methods should be used. And another publication of our group, optimization and standardization of surgical methods are expected not just to improve postoperative outcome, but also to enable comparison between different departments and surgeons. Same concerning endometriosis. Now, preterm birth, another complication. Women with endometriosis have increased risk of preterm birth. Hormonal imbalances, inflammation, uterine abnormalities associated with this condition may explain this risk. Endometriosis associated with increased risk of preterm birth and compared with unaffected women women with endometriosis also had an increased risk of pre-eclampsia and the risk to deliver with cesarean section. There are also placental complications for women with endometriosis. Potential association between endometriosis and placental complications, such placenta as placenta previa and placental abruption. In a meta-analysis, it's a huge group of nearly 100,000 pregnancies with endometriosis compared to over 7 million pregnancies without endometriosis. Endometriosis was associated with a higher rate of placenta previa, which is significant. Placenta previa and postpartum hemorrhage were significantly increased in the endometriosis group compared to the control group. Endometriosis significantly increased the odd ratio for placenta previa, as also you can see here the difference. Endometriosis and obstetric complications may share common pathophysiologic mechanism in which abnormal activation of inflammation, structural functional alteration in the junctional zone, and perturbed uterine peristalsis may play important role. Now, how does endometriosis affect reproduction? The mechanism of the linkage between endometriosis and obstetrical complications are hormonal imbalance, dysregulation, change of hormonal levels, mainly the estrogen. All this could affect the uterine lining, affecting implantation and pregnancy maintenance. Inflammation, uterine abnormalities. And now I would like to give you some food for thought. There is sufficient evidence to conclude that there is an increased risk of developing clear cell and endometrioid epithelial ovarian cancer for women with histologically verified endometriosis. Endometriosis is a risk factor for ovarian cancer. Endometriosis-associated ovarian cancer, most commonly clear cell carcinoma, is believed to develop from ovarian endometrial cysts. Professor Eitan Barnea, about 35 years ago, found a 14 amino acid structure, which is developed after the first, let's say, in the stage of 2 cells of the embryo. And this PIF, probably its role is to send a message to the mother, I am not a foreign body. So therefore, we all know that pregnancy seems to be a foreign body, and still the mother tolerates it. Now you can see here immunohistochemical evidence of PIF in uterine cancer, for example. And PIF was identified in endometriosis, but not in normal endometrium, implying that PIF, pre-implantation factor, might be expressed in rapidly dividing cells. Now, in Berlin, at the Charité, where I'm associated with, we sent 6 ovarian cystic serous cancers. We tested them for PIF expression. All of them were found to be positive. Thereafter, 193 samples from ovarian cancers were tested for the expression, which might reveal the correlation between the PIF level and the malignancy of the tumor. In 80% of the expression of the women was found to be positive. Now, right now we are repeating this test. We sent all these 193 samples again for re-evaluation. And we at the NESA, we started the International Oncological Advisory Board where we sit people from several countries and we discuss several cases. And we believe that we will be able in the future in some cases to find the connection between PIF, ovarian cancer, and maybe to find a way how to treat women with ovarian cancer. Now, implication for patients and obstetricians. Patients with endometriosis should be closely monitored during pregnancy, and healthcare providers should be aware for signs of complications. Pre-pregnancy counseling and early intervention can help reduce the risk of associated with endometriosis-related complications. It is suggested to women with endometriosis to receive prenatal counseling. They should be considered higher risk in pregnancy and at delivery. The conclusion, the evidence concerning linkage between endometriosis and obstetrical complications underscores the need for research and clinical awareness in order to manage pregnant women with endometriosis and to improve maternal and neonatal outcomes. It's very important that a woman with endometriosis should be in good hands. Thank you so much for listening.
The standard accesses for an operative laparoscopy are 10 mm access for the umbilical trocar and 2 or 3 5 mm suprapubic accesses. To avoid a suprapubic laparotomy, we performed the colon resection through the posterior vaginal fornix. This video shows the removal of a rectovaginal endometriotic nodule with the opening of the vaginal fornix. The colic resection is performed vaginally. Subsequently, the night griffin anastomosis is performed laparoscopically. Thanks to the introduction of one-port surgery, we can also carry out colon resections through the 2.5 cm incision of the umbilical axis. In this video, we show one-port anterior resection of the rectum and left ureterectomy with uteroneocystostomy for bowel and ureteral endometriosis. After anterior rectal wall dissection and posterior rectal mobilization, a rectal section is performed. Then we perform the resection of the left ureter with ureteroplasty. At this point, we perform the transumbilical extraction of the specimen. Finally, we carry out the night griffin anastomosis. After the removal of the single-port device, the ureteroneocystostomy is performed directly through the umbilical opening. This is the scar at the end of the procedure. Over the past few decades, while surgical procedures have become less invasive, the invasiveness of anesthesia has not seen a corresponding decrease, frequently leading to disagreements between surgeons and anesthesiologists. In recent years, we have developed an operative laparoscopy called OLIX that does not require general or spinal anesthesia but only sedation and local anesthesia at the entry point of the trocars. The OLIX sedation protocol includes premedication with midazolam and emlacrine, analogous sedation with remifentanil and propofol, local anesthesia at the entry points of the trocars, and paracervical block, postoperative analgesic therapy. Oleg's surgical protocol includes mild Trendelenburg position and multifunctional instruments for simultaneous cutting and sealing. A multimodal system displays prospectively propofol and remifentanil concentrations at the effect site and their interactions. It also displays the stage of sedation and an instant numerical calculation of the synergistic effect of hypnotics and analgesics. This slide shows the first paper published in the literature describing 5 cases of salpingo-oophorectomy in conscious sedation. Our second publication shows the extension of the technique to several pathologies, including endometriosis. The results of this technique are listed here. 74 salpingo-oophorectomy plus 1 with also omentectomy, 4 enucleation of ovarian cyst, 7 laparoscopic myomectomy, 27 ovarian cancer triage peritoneal or ovarian biopsies, 15 ovarian drilling, 33 laser ablation of endometriosis, and 5 LUNA procedures. Thus far, we have performed 166 operative laparoscopy under conscious sedation. The mean duration of pneumoperitoneum was approximately around 25 minutes, with a 10% rate of conversion to laparoscopy under general anesthesia. An optimal pain control was reported in all cases with VAS score lower than 4 when reported. No severe adverse events occurred, with hospital discharge in all unconverted cases after 6-18 hours, with a considerable satisfying rate. In this video, a perfectly conscious patient is undergoing laser laparoscopy of pelvic endometriosis. The anesthesiologist shows the monitor to the patient while the surgeon explains how to proceed. In the past, the operating theatre was illuminated by sunlight coming from this skylight. Subsequently, the use of surgical light significantly improved the view. The advent of video laparoscopy has allowed a more detailed view of the operating room. A resection for bladder endometriosis can easily be performed under laparoscopic view. By transilluminating the bladder with a cystoscope and using the firefly system of the Da Vinci robot, all the localization of endometriosis on the bladder appear more evident and easily resectable. Ureterectomy with ureteroneal cystostomy is often necessary in case of ureterial endometriosis. However, in case of extrinsic ureterial endometriosis, using transilluminated ureterial catheters and firefly system, a better view of the ureter would allow a safer uterolysis as shown in the slide right below. In this video, the rectovaginal septum is visualized with Firefly by transilluminating the rectum with a rectoscope and the posterior vaginal fornix with an illuminated uterine manipulator. At the end of the 70s, Maurice Bruhat and Yona Tadia were the first to use the CO2 laser in gynecology. Kamran Nezat later coined the term videolaseroscopy. Lasers do not touch tissue. The depth of the incision is controlled by the power density and the amount of time the laser is focused on the spot. This action at a distance allows for greater accessibility to the target tissue and less tissue trauma. Videolaseroscopy using CO2 laser has played an important role in selected gynecologic operations. The CO2 laser is absorbed by water. Hydrodissection is used to dissect areas near the bowel, the bladder, the major blood vessels, and the ureters. Superficial peritoneal endometriosis is safely vaporized. Bowel endometriosis is shaving using the scanner-assisted ultrapulsed CO2 laser in order to reduce the thermal damage of the tissue. When used in ultrapulse mode, the laser achieves more rapid vaporization and decreased carbonization. In order not to lose the undoubted advantages of videolaseroscopy in reproductive surgery, we have started to use the laser in robotics, using an introducer and a hollow fiber that delivers the laser to the target. As we reach the end of our presentation, we would like to express our gratitude for your attention.
Worldwide EndoMarch 8 years ago, we have made significant progress, thanks to all of you. But we have a long way to go. For example, due to your efforts and Worldwide EndoMarch, we have been able to now find or have at least an app to diagnose endometriosis, or at least guide to some degree diagnose patients with endometriosis who have pain and also, or they want to get pregnant. Patients who have tried to get pregnant, all of their tests are normal, their husband tests are normal, they don't get pregnant. A high percentage of these patients, they have endometriosis without any symptoms at all. The app developed by the Worldwide EndoMarch and Najat Family Foundation is now available free of charge to all the patients and interested parties around the world, that they can download it, use it, and guide them and help them to seek appropriate help. Or if they have significant amount of pain and they think they might have endometriosis, this app could guide them in the right direction. And significant other efforts being made in other directions by all the universities around the world. And these are because of your interest and your encouragement, and we thank you for that. You can easily find many of these advancements or the past webinars about endometriosis of the different organs like bowel, bladder, ureter, diaphragm in the webinar session of the Worldwide EndoMarch. You can find a session about diet, what to eat, alternative treatment on the webinar session. And you can also find any other interested topics that you want on the Worldwide EndoMarch web. The session today is dedicated to early detection of endometriosis. Recently, Dr. Sinan Nejad published a book very popular about this subject, and he is going to direct the session for today. Dr. Sinan Nejad happened to be my brother, and he has significantly contributed to the advancement and understanding and more care about endometriosis. He has devoted his life to patients and teaching the patients, and also teaching other physicians internationally, again, in respect to endometriosis. I welcome him, and I would thank you again for your attention. Dr. Sinan Nejad.
Hello, everybody from around the world. Thank you for joining us today, and thank you, Cameron. I'd like to thank all the patients who have been the advocate about themselves and getting this session more successful. The idea of endometriosis awareness has been going on for years, but unfortunately, in spite of all the organization approaching the societies, it did not get enough attention until the patients themselves became involved and became self-advocates. So on that line, 10 years ago, we had a World Symposium on Endometriosis in Atlanta, about 60 experts from around the world, and about 600 participants, including the patients. And Dr. Cameron Nejad gave a keynote speech about endometriosis and ancient disease. And reality was that for thousands of years, unfortunately, the problem of the women have been overlooked, and basically they were taught that, okay, you are a woman, you're born with this condition, live with it. They have called it hysteria, etc. So on that meeting, it dawned on us that the patient advocacy probably would be the best approach. So Dr. Cameron Nejad with the idea came, and we supported, and we created the EndoMarch, and that's where we are today. Going forward, personally, and also my brothers, we realized that a lot of these patients who come to us with advanced stages of endometriosis, they've had this problem, the symptoms for years. They've been diagnosed with irritable bowel syndrome. They've been diagnosed with interstitial cystitis. At times, they were diagnosed with psychological disorders. So we decided to put the focus on early detection on adult and increasing awareness about recognition of the symptoms on the early stages. So on that line, we published our experience on adolescent endometriosis, but it was for the medical journals. We went further, and for the first time, we published a book specifically on adolescent endometriosis. It's my pleasure that I have one of the co-editors of the book, Dr. Jennifer Dietrich, with us today, that she would speak. But before we go further, I'd like to invite one of our patients, Miss Emma Henry, to come and tell you her story of how she started at earlier than age of 14 with her symptoms. So Emma, are you with us?
Yes.
Hello, Emma. Emma is Emma Henry. Thank you for joining us. Tell us where you are and your story.
Well, so yes, I'm Emma. I really appreciate this opportunity to speak today. I live in Greenbrier, Arkansas. So the story starts about 8 or 9 years ago, a long time ago. When I was in 4th grade, I was about 9 or 10. I started having acne before everyone else in my grade. Lots of premature development going on, and the kids on the playground would be like, what are those dots all over your face? And there were a lot of mental repercussions with things like that. And so I got a little older. I got into 5th grade. I moved schools. I moved 3 hours away, different part of Arkansas, and I had terrible acne. My body hair growth was overwhelming, much more than any of the girls that I was friends with were experiencing. Lots of early breast development. And when I was in 5th grade, I was a gymnast, and we started to notice some masculine features begin to occur. My leg hair was dark and coarse, like a man's beard. And I was able to accumulate muscle mass very fast as a gymnast. I had zero flexibility, which caused a lot of injuries for me. But we noticed all these things were off. I never felt great. And my acne, it just got worse. And then in 6th grade, when I was 11, I started my period. And immediately it was extremely heavy flow, lots of pain that radiated all around my torso into my spine. And there was so much pain, the acne just kept getting worse. I eventually got to a point, I have some pictures, and this is not a very good quality picture, but this is when I was 12, and very bad acne, very painful acne. So my dermatologist thought that it would be a good idea to start birth control pills for the acne and to hopefully bring some regularity to my cycle. But she wanted me to see an OBGYN for that because I was so young. So I went to the gynecologist, and he started me on a birth control pill. The first one I took, I had a terrible side effect. I had migraines, and I was put on amitriptyline for the migraines, which just sort of messed me up. It was not a very pleasant experience. I wasn't acting like myself. I couldn't focus in my classes because they were daily headaches. It was like clockwork, and I never found relief from that. So he was like, okay, let's try another one. The next one, I had hair loss. There was a spot about the size of a quarter on the top of my head that the hair just fell out. It just left. And so I was put on Rogaine for that. And he said, basically, there's 30 something different birth control pills. We're just going to keep trying them until we find one that works. But I was so miserable from those experiences that we decided to stop. But with that, my cramping got worse. My acne got worse. My back pain started to get very bad. And so a pediatrician put me on meloxicam for pain. And over time, that started to give me very bad heartburn, chest pain, acid reflux. And so then we discovered that I had stomach ulcers from that. So I was put on Nexium. So all these medications are just sort of accumulating through this time. When I finally get to 7th, 8th grade, I'm 13, 14 years old. I had to quit gymnastics because I tore my ulnar collateral ligament in my elbow because I was so tight. Everywhere was so stiff and injured. It was a terrible injury. It was a year's worth of physical therapy. I started to gain weight pretty rapidly. The cramping was, it was unbearable. I couldn't just sit in class and deal with that. It was too much. But I never said anything to, people other than my mom, because I thought that's what every girl was going through. I thought it was just a normal, difficult time, and it was just something that I would get through and it would eventually be okay. But I started to realize that no one seemed to be bothered by it quite as much as I did. And I thought maybe I was being a baby about it. And I was terrified of admitting that. Gymnastics coaches sort of train you to never complain about pain. So it was difficult. Eventually the back pain and the cramping, it sort of migrated into the rectum, and I had terrible constipation, and everything, it was so painful just sitting down. I could feel it was so much pain. And so eventually my mom, who was a nurse practitioner for, I think, 25 years, she confided in one of her doctor friends and told her all of my symptoms. And she recommended for us to see Dr. Sienna Najat. And so out of the blue, we were like, okay, let's travel to Atlanta. I'm so fortunate that my dad is a pilot, so making the trip is not that difficult for us. But we go, and I get ultrasounds, and we look at everything, and Dr. Najat says that there's a high probability that I have endometriosis. We schedule a surgery and a laparoscopic surgery, and just like a month after that first consultation, we had the surgery. And I remember waking up. My parents were very nervous because I think it took about 4 hours. It took a long time. And I remember waking up, and I remember my mom telling me, like, you had endometriosis. It was stage 3 out of 4. It was really bad. We've done the right thing. And I just started bawling. It was overwhelming because I was nervous. I was like, you can't see it. It's not such an obvious thing. There's all these signs and symptoms that point towards it, but I was still very nervous about everything. And it was an immense weight off my shoulders. And so after the surgery, which I was able to heal very fast from, thank goodness, because it was a very easy process. I had a little bit of trouble, regulating cycles. I was put on Mirena, and for a while I did not have a cycle, but they began to come back. And so we added NuvaRing, and now I have very little cramping, very little flow, very manageable, normal cycles to deal with. There was a point where I had a benign mass in my breast because I had fibrocystic breasts. So I had to get that removed. But one of the main things, other than the surgery, that I think has brought me relief is I had to make a big lifestyle change. I had to change the way I ate. I drastically changed my diet. And you can tell in these pictures, this is when I was 13. And these pictures are exactly a year apart. You see my brace from my injury, the terrible acne. I was overweight. I was muscular. I was almost anemic. Lots of bodily pain. Everything hurt. Everything was exhausting. And this was exactly a year later, about a month or two after surgery. And it just seems like there was so much more life in me after that. I could not be more blessed than I have been to have the resources that I've had, because I don't know what I would have done. I think the original gynecologist I went to would have had to, give me a hysterectomy very early in life, I would not be able to have all the babies that I want to have one day. I love babies, and I'm so glad, because there was a time in my life where I thought that was not going to happen. And now I'm here, and I'm in college, and I'm doing all these things with my life that I could not deal with. I could not push through with such discomfort and such pain. And so it has been so amazing to be able.
Wonderful. Emma, thank you so much. One thing I have to tell you, your skin looks beautiful. So we're very proud of you. A few things, remember, for your history. Emma was 14 years old when she came to me, but before she comes, she has been in the emergency room. She has had MRI, CAT scan. They have checked in all the area. And from one medicine, at one point, they even have given her narcotics at the age of 14. So that brings us now that two factors from Emma's history is, one, that she also had polycystic ovaries. Polycystic ovary is a high estrogen level who could stimulate endometriosis. There is a misunderstanding that polycystic ovary patients could have high testosterone, and testosterone could suppress the endometriosis. That is not true. And I like patients to be aware of combination of symptoms and the condition that Emma had, that you could have a combination of hormonal imbalance in addition to endometriosis. So am I correct, Emma? Wonderful. So on that line, I'd like to invite Professor Jennifer Dietrich from Baylor to, I know we don't have a lot of time to elaborate, but mention how many, because she's an adolescent and pediatric gynecologist. Tell us why symptoms of people like Emma is so overlooked in the medical community.
Yes, thank you so much, Dr. Nazat, for having me. And, thank you everyone for joining us from, all over the world. This is really amazing that we get to share knowledge today. But yes, as a pediatric and adolescent gynecologist, this is certainly something that is on our radar screen quite early for young girls. We take care of girls from birth all the way up to 21 usually, but certainly, we're seeing young girls earlier because we do see that many young girls are presenting with puberty earlier, just as Emma shared with her story. And Emma, thank you for sharing all of that. It was very brave of you to do that. I think that because we're seeing girls early, we're having the conversation about periods and really what they're like. They're a little bit more comfortable describing the symptoms that they have earlier in life, which is really great. And because perhaps their mothers have gone through something similar and they don't want their child to go through what they went through. We are certainly going to have a heightened suspicion when there's a family history of endometriosis or polycystic ovaries or other gynecologic conditions, to look for a similar condition, because that tends to run in families. And when girls are having significantly heavy and painful periods from the time that they start their first period, it heightens our suspicion for several things. One of which is to look for any anatomic difference, where we're looking at the development of the uterus and the vagina. So through that, we can confirm if the anatomy looks normal. And then we cannot really see on ultrasound, as Emma mentioned, any evidence of endometriosis most of the time. It is frequently microscopic. And in these young girls that we frequently see at Texas Children's Hospital, it is one of those things that will ultimately require a laparoscopic diagnosis. Now, we have to balance a lot of different factors. We have a teenage population who's busy with school and sports and things like that. And so, having a surgery is sometimes disruptive to their routine. But if they opt to do a trial of medical management for 3 or 4 months, we may try that. But if they fail that, we kind of really encourage moving on to make a diagnosis from there, because we can ultimately access better treatments and we can pair surgical management with medical management. This is ultimately going to be the best for their long-term fertility and their long-term health, both physical and psychological. And then I think the other thing to just mention is that we really do try to approach it from a multidisciplinary standpoint. So while we want to balance all of the factors with regard to addressing pelvic pain in young women, part of the hard thing about addressing pelvic pain is that there's so many different pelvic organs in the same spot. That's why many times these young women are going through multiple different tests to try to figure out where the pain source is. And ultimately, one of the things we still have to manage is sometimes the musculoskeletal pain. And so we do try to set up some of our girls who have endometriosis, especially when it's advanced, with a physical therapist, because sometimes they need to rebuild their core muscles. And in addition to medical management and prior to that, surgical management, kind of helping to manage some of the musculoskeletal symptoms that they developed over time can be really beneficial to the long-term care. And so I'm just glad that there are more of us these days. Our specialty has been a burgeoning specialty really since the 1980s. And there are many more of us available and accessible all throughout the country to young women. And so I do hope that they come in and see us.
But how long it takes for these young girls to be referred to you by the pediatricians or by the doctors? Not everybody is even aware of your subspecialty these days.
Yeah, I mean, that's exactly right. So, you know, it can sometimes take years for people to get to us. This is partly because, you know, maybe they're looking at other sources of potential pain that might be down in the same pelvic region. And, you know, if they don't respond to courses of treatment, either from a GI specialist or from a urology specialist, or perhaps even, you know, maybe they've seen an orthopedic surgeon or a neurosurgeon because of neuropathic pain, sometimes it's years before they come and see us. And I would say that we see the girls sooner when there's a family history, because the parents put 2 and 2 together and say, I had this, and I think I'm going to take my daughter earlier for evaluation.
That is an excellent point. In our practice, when I say our practice, mostly my brothers and myself, majority of our patients are referred by other patients. It's a lot of time the symptoms are overlooked by their physician. Emma's history, I mean, is perfect. Had her mother not called and looked around and called another doctor, who by accident, it happens that she was a patient of mine, and when she came to my office, she was a pediatrician, the worst case of endometriosis. So I started working with that pediatrician, telling her, pay attention to your patient's symptom. And that was Emma's mother used to work with her. It came through patient and the mother, exactly that's what you said. So that brings us to the next part I like to say. Unfortunately, the awareness amongst medical community, even today, is not that much about on early detection of endometriosis. On that line, I like to invite my fellows to come and tell you when was the first time they even get exposed to endometriosis. I usually travel, do volunteer work around the world and teach and advocate awareness about endometriosis. And I usually have one fellow, but because of the COVID, I haven't been traveling. So this year I have 4 fellows. So I would like to invite my fellow, Dr. Tosin Odunsi, to tell her story, then Dr. Du, then Dr. Hincape, and Dr. McGrail. Go ahead, Tosin. Dr. Odunsi?
Thank you so much, Dr. Najat. And it's been such a pleasure being here and hearing the story of Emma and having Dr. Dietrich give her perspective as well. And I'm so grateful for this opportunity to study under Dr. Najat and take care of the patients that we do. In terms of when I heard about adolescent endometriosis, I did my medical school training at Meharry Medical College in Nashville, Tennessee. I also got my MPH in Philadelphia, did my residency in Connecticut. And it actually wasn't until I came here to Najat Medical Center that I learned about adolescent endometriosis. And I was very surprised because we're taught that this is an adult disease. So I was very shocked to learn about it. And I'm so grateful that Dr. Najat has been able to write a book about it and make parents aware of it, make the younger patients aware of it. And also, as I'm leaving fellowship, I'm able to educate my colleagues about how to recognize it and just bring about awareness as I go on with my future steps as well. So thank you so much for doing this.
Thank you, Dr. Odunsi. So you have your master's in public health.
Yes, sir.
Was there any mention during your training about endometriosis?
No, not at all.
Okay, so thank you very much. I'd like to ask Dr. Du to come, and she's Dr. Du also, her story would be interesting. Go ahead. Thank you, Dr.
Hi, everyone. Thank you very much for giving me this opportunity and join this meeting and have a chance to talk about a little bit how do I know about the adolescent endometriosis. So I graduated from medical school in China and came this country for postdoc training. And I did several years research about the pathophysiology of endometriosis at Yale. And during that time, I worked with plenty of scholars from, different countries, but we pretty much talking about adult endometriosis. Never really, the adolescent endometriosis, this topic never really brought up till like, I think it was 3 or 4 years when I was doing research, there was a resident, she came to talk to me, said she wants to apply for the pediatric and adolescent gynecology fellowship, and she mentioned about this disease. But it's still a concept of disease. During my resident training, I never really had a chance to encounter one of the cases. And till now, I came to, study with Dr. Najat and read his books and about teenagers' story. I was shocked. I said, wow, this is a real disease. Usually we all know for adult endometriosis, it's gonna take like 1 to 5 years to get a diagnosis, but for teenagers, it's even take longer. And I'm so glad Dr. Najat, published this book. And I think it's very, very helpful for patients and also actually very helpful for the OBGYN physician to recognize this disease. Thank you.
Thank you very much. Emma, could you please come back, and I'd like to, the book that Dr. Du is referring and Dr. Dietrich was also referring, it's geared towards the physicians and also the patients. Emma, are you with us?
Yes.
Okay, thank you. So Emma really truly has become an advocate for endometriosis. In that book, Emma and her mother wrote the story, which I have had so many comments and compliments, the same way that Dr. Dietrich told her, thank you for sharing your story. It takes a lot of courage to be open-minded, come and tell your story, especially in this society that people turn things against you. The bullying, you said the kids were
and now you are in college. Of course, you look beautiful, you are smart, you are in college. Is it what, 4.5 years later from your diagnosis? On that book, we have addressed nutrition, polycystic ovary, but briefly, Emma, tell your story and your mom's story, that what you wish you had done, somebody had done for you on the very early stages. Wouldn't you wish you had gone to somebody like Dr. Dietrich or myself or people who are aware? Tell us.
Yes, the first thing I wish I would have known is that it's not normal, and it's okay to look for help. And of course, it seemed like there was no one around us that understood what it was or even suggested it. My dermatologist, I went to pediatricians, I went to the gynecologist, and it never came up. The one pediatrician that put me on Nexium and helped me discover that I had stomach ulcers said, you know, this might be related to a female issue. That's the most that he was able to suggest, but it would have saved a lot of pain and you know, for girls that experience this, just time, a lot of time. The quicker you act, the more likely you are going to be able to preserve fertility. And so having that resource sooner definitely would have been preferred.
Thank you very much, Emma. So this brings us to my next guest speaker, Ms. Nicole Shelley. So I want to let you know there are physicians that they are cognizant of early detection of endometriosis. Nicole, are you with us?
I'm here, hello.
Good. So Nicole is a perfect example of being very lucky, because her mother suspected, she said her symptoms are not normal. She took her to a doctor, Dr. Wayne Hudak, who was an endocrinologist before. He was an endometriosis surgeon, and he was cognizant that these symptoms are not right. So she didn't end up going to the emergency room, CAT scan, MRI. Her doctor properly diagnosed her at the age of 17. And I'd like you to share your story with us.
Thank you. And I just want to echo everyone. I'm super grateful for this opportunity and all of the work that y'all have done in spreading awareness of this condition. And I'm actually 5 days post-op. Dr. Najat operated on me on Monday for my second procedure. So I'm feeling a lot better already. And just very, very grateful for this community and this opportunity. But Emma, much like you, I was in and out of the emergency room. I was in and out of GI doctors, MRIs, endoscopy, colonoscopy, all before I was 17. I missed a lot of high school. I missed a lot of school. A lot of people didn't understand what was going on. I even transferred high schools because the public high school that I was going to was not exactly understanding of me missing so much school and my health and figuring out what was going on. I was also diagnosed with IBS, stomach ulcers, all of the above. I was given a script for Lortab in the ER when I was 17, which is terrifying looking back on it now. It all kind of started when I got my period around 12, just really bad cramps, really heavy periods. I got on birth control when I was 16 and I would bleed for a month. They'd try another one. I'd bleed for another month. You know, it led to back pain, insomnia. I was depressed. I was told it was all in my head. I would be, you know, mid-barf in the ER at 3 a.m. and the doctor would be like, "You're doing this to yourself." And one ER doctor even almost accused my mom of doing it to me. So it was very traumatic. It was very tough. And I'm 29 now. And even, you know, in this last go round of endometriosis before my surgery, which my endometriosis did come back. But like Dr. Najat said, Dr. Hudak was able to really manage my pain for as long as possible, my growth, my fertility. Dr. Najat can speak to how great I look inside there because I'm not sure, but everything was manageable. But this last go round, I was having some really bad pain in my left hip. And it started about 2 years ago. It would come with my cycle and then it would go away. And then it started to come more frequently and I couldn't get it to go away, muscle relaxers, Advil, Tylenol, and even going up to some mild painkillers. Nothing was really helping. It finally got so bad that I could not walk one weekend and I was terrified. I was having panic attacks. I went to my general doctor on Monday and she looked at me and I said, I have endometriosis. Could this be related? And she said, no, there's no way. I don't think so. And I was that little 17-year-old girl in the ER again, feeling like I was crazy and I was doing this to myself and it was my fault. And this was all in my head. And even as a 29-year-old woman, I was scared and I felt silly and crazy. And 2 days later, I was in Dr. Najat's office and he told me, Nicole, it's basic anatomy. Of course, it's your endometriosis. He was like, your uterus is pulling on everything. So it just to be validated in that way was so powerful for me. I just burst into tears because it's such a long journey that even now that I'm 12 years in it, they still, it can happen where they don't believe you. But luckily, as Dr. Najat said, when I was younger, my mom went into Dr. Hudot's office. It was her, luckily, thank God, it was her gynecologist. And she was sobbing and she said, can I please tell you about my daughter? I don't know what's going on. She's been sick for over a year. She's been diagnosed as having a parasite at one point. They were just throwing things at me. They really didn't know. And Dr. Hudak said, I know exactly what she has, bring her in. And within a month, I was in the operating room and I was feeling so much better. I went to college in Dallas, Texas. Now I live in Atlanta. I work in Atlanta for Compass Real Estate, and I'm excited to get back to work. Maybe not Monday, but soon next week. Really feeling like I've turned a corner after my surgery on Monday, and I'm just so grateful.
Thank you very much, Nicole. There are a few points you brought out I'd like to elaborate. One is going to the right doctor. Two, the right doctor sending you to the right surgeon. The reason is, unfortunately, endometriosis treatment requires expertise, especially in the teenagers, younger people. The goal is to do no harm. We would not want to harm anything. And when they tell you endometriosis, I excised it for you and you are cured, that is not true. Endometriosis does recur. I mean, with all due humbleness, the method that we have developed, and I say actually it is Dr. Cameron Najat's original development, and we have elaborated on it. The method of excision that we use, it is not just cutting. We do excision with precision. We do it with microsurgical principle. That way we do not damage the surrounding tissues, not just going and cutting. Sometimes when Emma says her surgery took like 3 hours because she had endometriosis on her bladder, bowel, we don't go and just cut it. We go like micro knitting, cell by cell vaporizing. It is better to take a longer time and do the treatment with precision so it would not cause damage. So she was a perfect example of had early detection by a proper endometriosis aware physician. She was properly placed to the right place. She had proper treatment with all due humbleness. I'm not bragging about what we did, but that is true. And the second look that we did. Now, when her symptoms came back, in spite of suppressive therapy, I was aware, we did a second look, and truly the endometriosis is coming back. Nothing as bad as it was before, And it gave us the idea that she had no damage to the tubes, ovaries, or the uterus. So what Dr. Dietrich says, managing after the surgery is also important. Putting on medication, being awareness, sometimes physical therapy. So Nicole, thank you again for sharing, and now gives hope to people like Emma that 12 years later, back and normal and everything is good. So on that line, I'd like to invite our other fellows, which are fellows of Society of Reproductive Surgeons. Their focus is fertility and fertility sparing. Dr. Maria Hincape, go ahead. Tell us your story.
Good afternoon. Thank you so much, Dr. Najat. My name is Maria Hincape. I am originally from Colombia. I did my med school training in Bogota and my residency training in Cali, Colombia. And it wasn't until the first year of residency that I really learned about endometriosis, but I did not receive any specific training on adolescent endometriosis. And this was during the 4 years of residency. It was only until I joined Dr. Sina Najat for fellowship that I truly learned about this important topic. And I really want to thank the Drs. Najat and everybody involved in EndoMarch for providing this space for both patients and providers, and for highlighting the importance of this topic. So thank you so much.
Thank you. So we are having from the Colombia, Latin America, you heard about China. Now, I have a recent graduate, Dr. Kathleen McGrail, that she tells you about when she learned about endometriosis, her focus, and she is also fellow of Society of Reproductive Surgeons, who is going to do infertility. Kathleen?
Thank you, Dr. Najat. Yes, so I did my 4 years of medical school at the University of Arkansas, and I did my 4 years of OBGYN residency at Louisiana State University. And I don't remember ever hearing about endometriosis when I was in medical school. And then when I got to my residency, it wasn't until I was in my 3rd year of residency where I really got any kind of formal education or knowledge of the patients with endometriosis. But it was definitely only adults that I saw at that time. So I didn't hear or even think about really adolescent endometriosis until coming here to this fellowship with Dr. Najat probably a month ago. So I'm very grateful to be here to learn more and to be able to spread that information. And I'm very happy that EndoMarch and Dr. Najat are bringing awareness of this disease across the world to both women and providers who need more information about it.
Thank you very much, Kathleen. So Dr. Dietrich, you heard the patients, you heard the fellows, you are in a highly respected academic environment. What would be your message to the patients and to our fellows, and what do you wish for the medical students and the teaching in the future?
Yeah, I mean, definitely, I think that for the patients and families, our pediatric and adolescent gynecology field has really expanded. And part of the reason that we have done this is that we are truly advocates for children and adolescents. This is our specialty, and we don't just see problems that typically affect adults that are kind of presenting in earlier age groups. It really is different how we're managing these conditions and diagnosing these conditions early in life. We have to balance all of the factors of kind of making a diagnosis in order to help a child move forward through their academic career, but also balance fertility in the future. So we want to make sure we can make a diagnosis early, get them on the track of healing, even though we know that this is a condition likely to recur, but get them to a place where perhaps if we can treat early and suppress early, the recurrence is less, and the effects on the pelvic organs are much, much less than they would have been if it had not been diagnosed. This is something that we are specialized in, and therefore we look for it early. there are warning signs. And so, you know, certainly what I tell all of my patients, even if they're just coming for a routine visit as kind of a well child check sometime between 13 and 15, you know, we talk about periods and what's normal and what's abnormal. If you are getting to the point where you're missing school several times a month, that's not normal. If you cannot do your regular activities, including gymnastics, that's not normal. There's something that is resulting in severe pain that really shouldn't just be managed with narcotics. There's so many other medications that are better these days so that people don't get addicted early either. And so we need to investigate. I think, you know, that's what I'd tell families is come seek us out so that we can have a conversation about puberty and periods and talk about what truly is perhaps normal or abnormal. We also are experts in managing conditions related to uterine anomalies and vaginal anomalies. Many of these conditions, particularly if they're obstructive, are going to be a setup for endometriosis as well. They go hand in hand. And so that could be something as simple as a duplicated uterus or even a septate uterus. We automatically think that endometriosis is going to be higher risk because it is, and the studies have proven that in these patient populations. And so we know to look for it. I would hope for medical students, and luckily at our institution, we have medical students rotate with us every month as part of an elective, and they get to see this. They get to engage in our team, seeing young girls sometimes as young as 11. You know, while I mentioned 13 to 15, we see girls from birth all the way to 21. And because girls are presenting earlier with periods and puberty, sometimes we may have a child as early as 10 years of age having severe periods, and we just might make a diagnosis then, believe it or not. So we are going to look for it. Our medical students are seeing this, and hopefully it inspires them to go on to engage in women's health, maybe perhaps even become specialized surgeons such as Dr. Najat, his fellows and his team, and or a pediatric gynecologist, such as many of my colleagues as well, where we can kind of help start that journey of diagnosis and treatment, and then help graduate you safely and not in pain anymore to the adult side and to a specialist such as Dr. Najat.
Thank you very much, Dr. Dietrich. Yes, we have one of your trainees, luckily, in Atlanta at Emory, and it's been a pleasure working with her. So thank you for teaching the students and increasing awareness. So on that line, we have Dr. Debra Lee and Shruti Agrawal. These are Dr. Kamran Najat's fellow. I'd like them to share their story with you if you are available online. Dr. Agrawal or Dr. Lee? Okay. By the time they come back, I'd like to go back.
I'm right here, sir.
Oh, go ahead. Sorry. Go ahead.
That's okay. Good morning. My name is Dr. Agrawal. I'm one of Dr. Najat's fellows. I'm his second-year fellow. I've been with him a whole year. So I can definitely tell everyone that even though I've learned so much about endometriosis with him over this past year, I realize how much more there is to learn, because being with him even now, he tells me every day that as long as you stay with me, you're going to learn something every single day, something that you've never learned before, which is absolutely true. I think in residency, we just do not have the opportunity to go into depth with endometriosis and realize how much there is to this disease. So I feel very lucky to be able to train with Dr. Najat and be able to try to solve the mystery of this enigmatic disease, as he likes to call it.
Yes. When did you first learn in your training? When did you first learn about endometriosis? Medical school or residency or?
Right, sir. I mean, with endometriosis, we do learn about it in medical school, but it is just in passing. It is one of the several things you would learn in the block of time you learn for obstetrics and gynecology. So it's definitely not given the importance or time that it deserves, because in med school, we learn so much that we kind of glance over endometriosis. And then even in residency, we just don't get to see as much of it in the hospital. And we're not very good with diagnosing it as general OBGYNs. I just don't think we learn as much as we should be learning about endometriosis.
And when did you learn about adolescent endometriosis?
Basically never, till I got to Dr. Najat, actually, to be able to see how young patients are presenting with the same symptoms as our older patients. I mean, as a general OBGYN, when we see younger patients with these symptoms and signs, we just think about starting them on birth control. We never think that it could be endometriosis or that they may consider needing surgery. So definitely adolescent endometriosis is not something that we learn a lot of at all.
Thank you. Dr. Lee, are you with us?
Hello, I am.
Yeah. Go ahead, please. Tell us your story.
Yes, absolutely. So I am from Texas. I did medical school in San Antonio and I did residency in Austin. I then actually was out in practice for 3 years as a generalist OBGYN. I do consider myself lucky that I had some exposure to learning about endometriosis in residency. We had a minimally invasive gynecologic surgeon who really worked hard to make sure we were exposed to endometriosis. But one thing that this fellowship has really made crystal clear for me is that endometriosis is a complicated disease. It affects many organs. There are many symptoms that are not typical, that are atypical symptoms, like many of the patients have spoken about, the GI and GU symptoms, you know, the thoracic symptoms. And then for adolescent endometriosis, it really wasn't until I got here, you know, and I think that it is really something that is, you know, important. I think it's going to be a very important message for us as fellows to kind of carry forward in our careers and to bring to light. And I'm thankful to have the exposure to hearing from patients, to being able to identify symptoms, and to also have the pediatric and adolescent gynecology lens as well. So I'm very thankful for this opportunity. So thank you.
Thank you very much, Dr. Lee. So we have a few more minutes, and I'd like to give the podium back to Emma and Nicole. In a minute or two, tell us about what you wish for us as healthcare providers to do for your children in the future. You are young, you will have daughters. What do you wish for them? Emma and Nicole, either one?
I can go ahead. I definitely wish that this was a condition that was asked about early on in a young woman's healthcare. We put it together pretty early on in my diagnosis that my grandmother and aunt both suffered from this. My grandmother had 5 or 6 miscarriages. My aunt ended up having a hysterectomy in her 50s, and she was just like covered in endometriosis. So I definitely, I hope that this is something that is, you know, it just becomes as normal as any other condition. You have a family history of diabetes or breast cancer or anything like that, because it's so misunderstood. And there's such a stigma around, you know, women's health, and we're complicated beings with complicated organs. And I'm just really grateful for all the research that you're doing so that Emma and I can have a better life.
Thank you, Nicole. Emma, are you with us?
Yes. Well, similar to Nicole, there is a little bit of family history. My aunt had to have a hysterectomy in her 50s, and then my mom had a partial hysterectomy with Dr. Najat, and she was covered in endometriosis too. I think that the work that's being done here is incredible, and while it hasn't been an easy process, I consider myself pretty lucky to be a part of this, because I'm blessed in the way that the events unfolded, but otherwise I would have not known anything about this. And now, having been through it, and hopefully all the other patients that have been through it, we can help be a part of this movement we are real people who have really experienced this. And I think that is going to be part of what it takes to spread the awareness, being on the front lines of it, being a firsthand experience of it. And I just wish that there was, it was more in the forefront of pediatricians in terms of young girls describing their pain. I wish it would come up more. I wish it was considered more, but I think that we will get there.
Thank you very much, Emma. Thank you, Nicole. And I really want to thank the EndoMarch organizers and the volunteers to keeping this message forward. I really appreciate all the faculty participants today and the speakers. So on that line, I would like to pass it on to Dr. Kamran Nejat. Thank you again, and it's a pleasure to be with you.
Thank you very much, Dr. Sina Nejat. I would like to thank you for that excellent program, and especially, and of course, I'd like to thank all of your guests one by one, Dr. Dietrich and all of your fellows, and especially Emma and Nicole for their brave history and for their very interesting background that unfortunately we see it every single day. It is very touching to listen to them and see how when their condition, the endometriosis, was diagnosed, that was a big weight lifted up of their shoulders. And it's unfortunate that we have to see this in this day of an age with so much knowledge, that young patients go and they're diagnosed for years and years. And we thank them for their participation and thank you for putting this excellent program together. We thank all of you for viewers around the world. Please continue your support to help the patient with endometriosis in your communities, in your countries, in your medical schools. Support your physicians, your surgeons, your researchers, your government officials to help and forward and make progress that finally we put an end to that entity. Please watch the former programs about endometriosis, and the webinars are all informative to you. Also, as I mentioned, there is an app. It is called Nejat Endometriosis Advisor. It is completely free all around the world, can guide you for further diagnosis of endometriosis if you have pain, or if you are trying to have children and you have not been successful to get pregnant. All of your tests are normal. Your husband tests or your partner tests are normal, and you are not getting pregnant. There is a high possibility you have endometriosis. Seek proper help and you could be helped. The next month program is going to be about chocolate cyst, endometriosis cyst, ovarian cyst, that sometimes patients like Emma that said that even had been suggested to have hysterectomy. Unfortunately, even now, we see young patients who have had hysterectomies, ovaries removed or destroyed because of endometriosis, and they are younger, they want to have children. There is a program, the guest speaker and the guest program director would be Dr. Farnejad for the next month, for the month of September. And once again, we thank all of you for your participation and wish you a wonderful month until we see you for the program in September. Wishing you a great day and night wherever you are around the world. Bye-bye.
This video would demonstrate a methodical surgical approach for recurrence of endometriosis after a hysterectomy. The patient is a 35-year-old G1P1 who presented as a referral with pelvic pain and a history of biopsy-proven endometriosis. Her relevant history includes a hysterectomy about 5 years ago, and she recently underwent a right oophorectomy within the last year. The operative report from her right oophorectomy noted that the right ovary and tube were encased in bowel adhesions with a 3-centimeter endometrioma. The left ovary was also encased in bowel, and they were unable to fully evaluate the left ovary. Endometriosis implants were also noted along the abdominal wall. Therefore, she was consented for a diagnostic laparoscopy, resection of endometriosis, and cystoscopy. Entry is obtained through the left upper quadrant, and a survey is first performed, with mindful attention to all peritoneal surfaces. The survey begins in a systematic fashion, starting with the liver and diaphragm on the patient's right, which is followed to the falciform and the diaphragm on the patient's left and stomach edge. Next, attention is then drawn to the pelvis, which demonstrates significant sigmoid adhesions to the left sidewall, obstructing the left ovary. Next, you can see the remnant of the right round ligament and infundibulal pelvic ligament along with the gunpowder lesion seen just inferior. However, we need to get a closer look, so we continue our survey in the posterior cul-de-sac to find even more gunpowder lesions, consistent with recurrent endometriosis. As we pull the camera cephalad, there are abdominal wall lesions on the right lateral side of the patient. One must stress the importance of a detailed exploration for any signs of endometriosis over all peritoneal structures. Now that the survey is as complete as it can be for the time being, our first goal is to restore normal anatomy. This commences with adhesiolysis of the sigmoid adhesions to the left sidewall. The assistant begins by grasping bowel epiploca for traction, as the surgeon uses a combination of sharp and blunt dissection to complete their adhesiolysis. While cutting the filmy adhesions under tension, this allows for ease of dissection. Mindful attention is paid given the proximity of the bowel to the sidewall during this dissection. The combination of blunt and sharp dissection is absolutely essential, as bowel and redundant peritoneal tissue can look very similar, so the importance of thinning out the tissue with blunt dissection before cutting is crucial. Not only to avoid injury to bowel, but in this region, to avoid injury to bladder. Once some of these adhesions are dissected, one can see the enlarged ovary inferiorly, as well as the other endometriosis lesions along the sidewall. The bowel is almost restored to normal anatomy. However, there is denser adhesion to the left sidewall just superior to the ovary and fallopian tube. Once again, the bowel epiploca is placed on tension to help visualize the different planes. The adhesion is cut close to the safe area of the sidewall, away from the bowel. Atraumatic graspers aid visualization of the appropriate plane by placing tension on the bowel. The bowel is now more mobilized but still has adhesions on the posterior aspect of the ovary, which are lysed by blunt dissection. This has freed the ovary some and allows the ovary to be moved toward the interior abdominal wall. Aha! Here we see a large endometriosis lesion along the pelvic sidewall, the culprit of our peritoneal fibrosis. The tension placed causes leakage of the endometrioma, spilling the classic chocolate cystic fluid, which was quickly and copiously suctioned to prevent further pelvic irritation. The suction is used for further blunt dissection of the left ovary off the pelvic sidewall. The suction irrigator is an excellent additional tool for blunt dissection, as demonstrated here. Next, attention was turned to the right sidewall by first dissecting the thin bowel adhesion from the right remaining adnexal structures. Given the extent of endometriosis and significant peritoneal fibrosis along the right pelvic sidewall, right ureterolysis was performed. The course of the right ureter was identified, and the overlying peritoneum was incised sharply at the pelvic brim. The retroperitoneal space was entered and dissected with a combination of sharp and blunt dissection, and continued inferiorly. One can see the tension placed to move the bowel medially away from the operative field, and the tension placed anteriorly on the overlying peritoneum to aid in this dissection. Atraumatic graspers are used to bluntly dissect medial to the ureter to allow for optimal lateralization of the ureter. Here is an excellent view of the ureter. The dissection is continued inferiorly, but a denser adhesion is entered. Not to fret. Once again, the combination of blunt and sharp dissection is vital. After making a small incision, blunt dissection is used with the same cutting instrument to thin out the tissue, making sure only peritoneal tissue is cut and not bowel. Ureterolysis continues inferiorly with continued lateralization of the ureter. Given the extent of the endometriosis lesion, lateral dissection is also performed. During this entire dissection, the ureter is constantly checked to make sure it is still vermiculating as it should. The assistant helps significantly with this extensive ureterolysis by displacing the ureter away from the operator's surgical field, allowing for a safe dissection. Here, dissection is performed lateral to the ureter, given the location of the endometriosis lesion. Here we see the ureter vermiculate along its length. This is a crucial portion of the ureterolysis, given the location of the uterosacral lesions next to the ureter. After ureterolysis is performed for the entirety of the ureter length to the uterosacral ligament, attention is then drawn back to the endometriosis lesion, which is grasped and tented toward the anterior abdominal wall while cut with an ultrasonic energy device. The tension changes depending on the direction of the operator's field. Like here, the tension is placed medially while the operator is cutting lateral to the mass. Given the density of this lesion, the instrument continues to cut but also thin out the tissue by blunt dissection. This is continued until the mass is amputated from the sidewall and placed in the posterior cul-de-sac until the conclusion of the case. Next, lesions on the right uterosacral ligament were grasped with cup forceps and once again using the ultrasonic energy device dissected with caution, noting the location of the ureter throughout the dissection. Attention is then turned to the right mid-abdomen to excise lesions on the anterior abdominal sidewall. The lesions were grasped with cup forceps and tension placed toward the operator to allow for circumferential dissection of the entire affected peritoneum, rather than individual biopsies. Careful attention was paid to make sure only the peritoneum was incised, as depth perception can be tricky, especially at this region of the body. A decent margin was acquired to make sure no residual endometriosis was left behind. Attention was then turned back to the left pelvic sidewall. Given the extent of peritoneal fibrosis, ovarian suspension was performed to improve the visualization. A stab incision was made in the left lower abdomen, and a Carter-Thomason needle with a 2-0 monocrystal suture was introduced into the abdomen. The needle was threaded through the left ovary, and the suspension was brought through the skin incision and held with a hemostat on the anterior abdominal wall. The assistant also helps minimize trauma to the ovary by helping tent the ovary up with the suspension. Ovarian suspension is an easy tool for improved visualization to optimize your surgical field, as well as free up additional instrumentation for dissection purposes. Back in the pelvis, there are filmy adhesions between the bowel and the sidewall, which were easily dissected. The overlying peritoneum at the pelvic brim beneath the left infundibulopelvic pelvic ligament was dissected, and the retroperitoneal space was entered. Notice the same surgical fashion is carried out for ureterolysis as it was done previously. Primarily tension with blunt dissection of atraumatic graspers to allow for lateralization of the ureter. Only sharp dissection was used on thin peritoneal tissue that was well away from the ureter. Again, blunt dissection was performed to push the ureter laterally to aid the dissection. During the dissection, the ureter is noted to be intermittently vermiculating. Ureterolysis is continued inferiorly along its entire length. The endometriosis nodule is grasped with cup forceps and tented toward the assistant's side, while the surgeon uses ultrasonic energy to dissect the nodule sharply. Blunt dissection with an atraumatic grasper allows for further thinning of this dense tissue for safe dissection. The dissection is continued with a combination of blunt and sharp dissection to mobilize the nodule off of the pelvic sidewall. This ensures the safety of the ureter. Again, ureterolysis continues for the entire length of the ureter, allowing for resection of the entire peritoneal tissue that is affected by the endometriosis. Another important structure to be mindful of in this location is the hypogastric nerve. Injury to this nerve can cause bladder dysfunction and painful intercourse. So it is important to be mindful to not jeopardize this nerve. Continued thinning of the tissue is absolutely necessary for ensuring only the endometriosis-affected regions are dissected, and no inadvertent injury to surrounding structures are damaged. It is easy to lose oneself in the pelvis when operating there for long periods of time, so reminding yourself of surrounding structures is important when you are dissecting sharply. It is easy to see that endometriosis was the culprit of this impressive fibrosis, that is causing a dense dissection, making these resections very tricky and dangerous, especially if time isn't taken to thin out the tissue with a dissecting tool before sharply dissecting. Once the lesion is dissected off the pelvic sidewall, it is important to evaluate the area for any more nodules or regions that might be affected. Next, attention is then drawn to the cul-de-sac, where numerous lesions are seen in the rectovaginal septum and uterosacral ligaments. The most anterior lesion is first grasped with cup forceps and dissected with the ultrasonic energy device. The dissection is continued to try to achieve margins with additional peritoneum incorporated into the specimens to ensure adequate endometriosis resection. A small EEA sizer is placed in the rectum to delineate the borders of the bowel. Cup forceps again were used to grasp the lesion and apply tension, while the ultrasonic energy device was used to sharply undermine this lesion. Once again, it is utterly important to thin out this tissue and fat, as an enterotomy is only millimeters away. The dissection was continued in the same fashion for the other lesions in this area. The EEA sizer was especially helpful, with the manipulator continuously moving it to various affected regions, aiding in the dissection. This final specimen highlights the techniques of rectal shaving. The surgeon is constantly being mindful of the depth of their dissection and continues the essential skill of thinning the tissue and dissecting it just underneath the cup forceps. After the completion of the resection in the cul-de-sac, the ovarian suspension is removed and the lesion superior to the infundibulopelvic ligament is addressed. The lesion is carefully grasped with the cup forceps, minding to only grab superficially to avoid injury to any underlying structures. Sharp dissection is easily performed. The left ovary is then grasped with atraumatic graspers and the salpingectomy is performed. Adhesions are noted between the fimbriate and the ovary, which is addressed with sharp dissection and cautery, staying close to the fallopian tube to avoid any compromise to the patient's only remaining ovary. Once the ovary is freed from these adhesions, the salpingectomy is continued with sharp dissection with the ultrasonic device along the mesosalpinx until it is amputated from its proximal site. The ovarian cyst wall of the previously ruptured endometrioma is then addressed. The ovarian stroma and the ovarian cyst wall are grasped by opposing surgeons, who utilize traction and countertraction to pull the cyst wall from the ovarian stroma. One maneuver that is easy to perform is grasping a fold in either the ovarian stroma or the cyst wall, allowing for an improved hold on this vital tissue, which will aid in dissection. Given increased vascularity at the ovarian bed of the cyst, the ultrasonic energy device was used for sharp dissection with cautery to remove the remainder of the cyst wall. All the specimens that were previously placed in the cul-de-sac were then grasped and placed in an endo catch bag and removed from the abdomen. The pelvis was then evaluated again for hemostasis, which was confirmed. Her surgical pathology resulted with numerous biopsies consistent with endometriosis, including an endometrioma, pelvic sidewall lesions, right abdominal wall lesion, uterosacral ligament lesion, and rectovaginal septum lesions. There are several learning points highlighted in this video. First of all, it is important to emphasize performing a systematic, detailed abdominopelvic survey to evaluate for any signs of endometriosis over all peritoneal structures. It is essential to restore normal anatomy and identify key anatomic structures prior to performing any type of excision. Remember to reorient oneself in the space, as it can be easy to lose oneself in the pelvis when working for prolonged periods of time. One must be mindful of the surrounding anatomy to avoid inadvertent injury to surrounding structures. When dissecting, thinning out the tissue prior to excision or continued dissection is vital, as an incidental otomy is only millimeters away. And remember to use other tools in your toolbox, such as utilizing ovarian suspension, which is an easy procedure for improved visualization to optimize your surgical field and freeing up an additional instrument for further dissection.
La Asociación Colombiana de Endometriosis e Infertilidad es una ONG sin fines de lucro que desde hace 12 años trabaja en educar, visibilizar y sensibilizar sobre la endometriosis y otras patologías uterinas que afectan a la mujer, promoviendo políticas para el diagnóstico temprano y educando en salud menstrual. Tenemos 3 campos de acción. El primero de ellos es el capítulo de afiliadas. Somos una red de apoyo para las pacientes y sus familias. Les brindamos orientación, información y las referimos con especialistas que hacen parte de la red de profesionales a nivel nacional para que tengan descuentos especiales y tarifas preferenciales en consulta, exámenes diagnóstico y otros tratamientos, además de pertenecer a nuestro grupo de apoyo y diferentes beneficios como talleres, charlas exclusivos para ellas. Además del capítulo de afiliadas, que es muy importante para nosotros, acompañando a todas las mujeres en el territorio nacional, tenemos también otro campo de acción que es la incidencia política. Promovemos políticas para el diagnóstico temprano y somos las autoras de la recién aprobada Ley Endometriosis Colombia, que protege los derechos de pacientes con endometriosis y otras patologías uterinas, además sentando un precedente a nivel nacional en cuanto a derechos menstruales. También hacemos incidencia a nivel territorial para promover el diagnóstico temprano y tratamiento adecuado a quienes tienen patologías uterinas en nuestro país. Nuestro tercer campo de acción tiene que ver con la pedagogía menstrual. Para nosotras es importante impactar positivamente a la comunidad y visitamos poblaciones vulnerables en todo el territorio nacional, donde hay niñas y jóvenes con difícil acceso a la salud, a la educación, y damos charlas educativas sobre salud y dignidad menstrual, sobre derechos sexuales y reproductivos, sobre soberanía corporal, entregando un kit menstrual que incluye un libro pedagógico que nosotras diseñamos y producimos para que puedan tener herramientas y recursos para gestionar de manera digna y saludable su menstruación y también poder promover esa salud menstrual, a su vez que conocer derechos sexuales y reproductivos para prevenir embarazo adolescente.
Escucharme y la oportunidad también de compartirles mi historia, especialmente agradecerle a la concejal Heidi Sánchez por la invitación. Hoy, en la conmemoración del Día de la Mujer, en el marco además del Mes Internacional para generar conciencia sobre la endometriosis, vengo a contarles mi historia brevemente. Hace 17 años me diagnosticaron una enfermedad crónica y que no tiene cura, se llama endometriosis. Seguramente muchos de ustedes jamás han escuchado la palabra endometriosis, pero déjenme decirles que estoy segura la conocen a través de las mujeres que hacen parte de su círculo más cercano. 2 de cada 10 mujeres padecen endometriosis, una enfermedad desconocida, incluso por las mismas mujeres, infradiagnosticada, infravalorada y minimizada por estar relacionada con un hecho biológico completamente natural como es la menstruación. Esta enfermedad durante años ha sido relegada. En Colombia, en promedio, el diagnóstico se da en 10 años en los que debemos soportar síntomas incapacitantes, en los que estamos rodeados de estigmas, en los que estamos rodeados de señalamientos y en los que se ve considerablemente afectada nuestra calidad de vida. A raíz de mi propio testimonio personal y después de pasar por muchos años de dolor, de incomprensión, de malos tratamientos o tratamientos inadecuados y de mucha indiferencia por parte de la misma sociedad, decidí crear la Asociación Colombiana de Endometriosis e Infertilidad, una ONG sin fines de lucro que trabaja precisamente en educar, en visibilizar y en generar conciencia sobre la endometriosis, teniendo en cuenta que en Colombia son más de 3.5 millones de pacientes diagnosticadas y más de 1.5 millones de personas con todos los síntomas pero que no han recibido un diagnóstico certero. Claramente hay vacíos en el sistema de salud y claramente nuestro sistema de salud no está preparado para atender la endometriosis. La endometriosis es un tema de salud pública que concierne a toda la sociedad y no solo a quienes la padecemos. Precisamente, gracias a los testimonios y a las historias reales de cientos de pacientes que llegaban a la asociación contando sus experiencias de mutilaciones innecesarias, de mala praxis y de mucho abandono, decidimos construir desde el colectivo la ley Endometriosis Colombia, el proyecto de ley Endometriosis Colombia, que lo que busca es proteger los derechos de las pacientes, pero también sentar precedentes en el país en cuanto a derechos menstruales. Y es a partir de las historias reales y las experiencias menstruales de las pacientes que nace todo lo que en la ley contemplamos. Hace un año, precisamente en marzo, fue aprobada la ley Endometriosis Colombia en el país y entró en vigencia en octubre del año pasado, y es una construcción ciudadana de la salud y los derechos menstruales que nace precisamente de las mismas pacientes.
We remember the late Dr. David Redwine, a luminary in gynecology and endometriosis surgery, who passed away on October 23, 2023. His solo practice was in Bend, Oregon. He made integral contributions to endometriosis understanding and surgical treatment. He always shared his experience globally through lectures and demonstrations. Beyond his clinical prowess, Dr. Redwine will be remembered as a respected colleague, a passionate advocate for patients with endometriosis. His analogy of studying endometriosis to astronomy showcased his commitment to unraveling complex diseases. Though his passing leaves a void, Dr. Redwine's enduring legacy as a symbol of hope and resilience in the fight against endometriosis will inspire generations to come. Our heartfelt condolences goes to his family, friends, colleagues, and countless lives he touched. He recorded this program prior to his passing, and we are happy to share it with you.
Hello and welcome to March Endometriosis Awareness Month. I thank Kamran Nijat for the invitation to share some thoughts. My name is David Redwine. I'm a retired general obstetrician gynecologist who spent my entire career in a small Oregon town. I had no special training in endometriosis or laparoscopic surgery and was never affiliated with a medical school or drug or equipment company. I've observed the endometriosis landscape for over 54 years, beginning in 1969 with my first wife who had endometriosis. What's changed in 54 years? Well, let's find out. 54 years ago, it was said that endometriosis is a mysterious incurable disease which sometimes requires hysterectomy and removal of the ovaries to treat. That is still said today. 54 years ago, symptomatic hormonal treatment with birth control pills, progesterone, or danazol led to disappointing treatment outcomes for many patients with associated medication side effects and a high symptom recurrence rate within weeks of stopping medicine, even in those patients lucky enough to have had some pain relief during treatment. This is the outcome that is still seen today. 54 years ago, hysterectomy and removal of the ovaries was considered definitive treatment. This is still believed by many physicians today. 54 years ago, endometriosis patients with pain were sometimes considered to be neurotic. This is still a problem today. 54 years ago, most gynecologists were male. Today, most gynecologists are female, yet they are dealing with many of the same problems their male predecessors dealt with decades ago. This indicates that the perception of lack of or slow progress around endometriosis is not related to gender. The problem is with the education and training surrounding endometriosis. Medical schools, residency programs, and fellowships must adopt modern concepts about the disease instead of repeating the mistakes of the past. 54 years ago, endometriosis was thought to be an auto-transplant, identical to the endometrium. Today, we know that endometriosis displays many, many differences from endometrium, so it cannot be an auto-transplant. 54 years ago, endometriosis was thought to be incurable. Today, surgical cure rates over 50% are documented following expert aggressive excision, with cure rates over 90% for intestinal and diaphragmatic endometriosis treated by excision. 54 years ago, endometriosis was thought to be caused by reflux menstruation, although at that time there was no photomicrographic proof of the steps of attachment, proliferation, and invasion. These steps would be impossible to miss if they occurred because of the large sizes of the cells involved. Without microscopic evidence, schematic diagrams and cartoons were presented as evidence. Today, reflux menstruation remains the most popular theory of origin of endometriosis, but still without the easily obtainable microscopic proof of the steps involved. However, modern schematic diagrams and cartoons have become more artful and more colorful. Continued acceptance of reflux menstruation at any level is one of the main things holding back progress on the disease. Rejecting reflux menstruation and embracing a genetic embryonic origin would be the single most important scientific act which would cause true progress to be made. 54 years ago, a gene was often viewed like a light switch. It was either off or on. Today, genes are viewed more like a dimmer switch with genetic and epigenetic mechanisms increasing or decreasing a gene's function and interactions with multiple other genes. 54 years ago, it was known that endometriosis tended to run in certain families, and that was the extent of our genetic knowledge. Today, a mulariosis gene ensemble is emerging from powerful genome-wide association studies, and this offers a simple explanation for the origin of endometriosis as a genetically based disease that is manifest in pattern tracks during embryonic formation, and which is genetically and developmentally related to other GYN pathologies like adenomyosis, fibroids, and peritoneal pockets. Removal of those pattern tracks is what enables cure to occur. Dozens or hundreds of genes are involved in the formation of endometriosis and its associated pathologies, so stay tuned to this genetic station because that's where advances will occur. 54 years ago, most patients with endometriosis would have no extra knowledge about the disease and would not question a doctor's advice. With today's internet, patients often come to the office knowing more about endometriosis than the physician. 2,500 years ago, Hippocrates spoke of the importance of a physician's fee for non-emergency work and how the fee should be discussed up front with the patient. The physician had to receive sufficient money to show up to treat a patient without feeling like he was being taken advantage of, otherwise he might neglect the patient. For the patient, a paid fee would be some insurance that the patient would be taken care of. Hippocratic medicine therefore consisted of fee-for-service medicine. Today, elitism by other surgical specialists and multiple layers of bureaucracy stand between physician and patient. This leads to inefficiency, expense, frustration, and sometimes confusion as to who is in charge. Hippocratic medicine has been abandoned. 54 years ago, GYN laparoscopy was used only for diagnosis or sterilization. Laparotomy was used for everything else. Today, any abdominal or pelvic surgery that has a name could be done laparoscopically. This is one of the great advances in the history of surgery, leading to shorter, safer surgery and recovery. 54 years ago, endometriosis was considered simple to treat surgically, and no federal codes existed to describe the simple, limited things that could be done in those days. Surgeons felt adequately paid for such quick work and could get back to the delivery room or office with ease. Today, we still don't have enough codes for what endometriosis surgery requires. I consider excision of endometriosis to be the most difficult elective surgery that can possibly be done anywhere in the human body. This is because of its invasive potential in so many separate organ systems. The general surgeons or urologists helping at endometriosis surgery will be paid more than the gynecologists because their code values are higher. Gynecologists are very low on the surgical respect totem pole, a result of being guilty in the past of doing only a few kinds of surgery before rushing off to deliver a baby. Ceding parts of an endometriosis case to other specialties will only solidify GYN surgery's low place in the surgical spectrum, which bodes poorly for any improvement in surgical fees within a system that is constrained to be revenue neutral. This problem has not been solved in 30 years of trying. Life can be a struggle, and each patient must fight their own fight without expectation of help from others. So resilience and strength become the hallmarks of many patients with endometriosis. You are a strong bunch of people because you have to be. Congratulations for that. I hope the future is better for everyone. So carry on. Thank you.
Точно така. Това е така, защото месец март е световният месец на ендометриозата. Навсякъде по света. Това е една инициатива, която за тази инициатива стои Worldwide EndoMarch. Една инициатива, която подкрепя страдащите жени от ендометриоза. Тази инициатива през целия месец март ще бъде в повече от 60 държави. В Worldwide EndoMarch участват над 100 организации по целия свят. Точно така. Месец март ще бъде целия в жълто. Навсякъде по света, последната събота на месец март, се провежда ендопоход. Уви, навсякъде по света, заради коронавирус пандемията, тази инициатива ще бъде онлайн, както и миналата година. Позволете ми да ви подаря един символ на тази инициатива – жълтата тениска. Заповядайте.
Благодаря ви, докторе.
Hello everyone, my name is Yana Pashova and I'm making this video to raise some awareness of the life of a patient with an endometriosis, and I'm reaching out to everyone else who is suffering so that I share what I've been experiencing. I was first diagnosed with endometriosis when I was 27 years old, and I did have my periods were regular but extremely painful, and actually in my teenage I was suffering with dysmenorrhea very often, but after that the periods were normal. However, I wasn't able to get pregnant at all, and I had a lot of symptoms prior to knowing that I have that condition. I had the pain, I had the swelling. For a whole week I would feel very uncomfortable. I would have digestive problems, I would have lower back pain and overall pain all over my body, all my muscles and joints as well. And I would feel very depressed. I would be retaining water and I would feel very tired and weak, and then I would lose a lot of blood and I was constantly anemic. I'm chronically anemic, and I experienced such severe pain that I actually passed out, and I had found out that I had a huge cyst, a diameter of 7, almost 8 centimeters. And urgent surgery was necessary, which was performed in San Francisco General Hospital. They said that the endometriosis was quite progressed and they weren't able to clean it completely. I have had to miss work very often. Sometimes I would not be able to work at all for a whole week. And actually almost every month I have been like crippled for a whole week. Before, during and after period, for a barely walk. Of course that affected my personal life, my sexual life, my marriage. Then I had a second surgery because the endometriosis on the ovary returned again viciously, and I had surgery in Sofia in my chin-dom by excellent surgeon, Dr. Bosev, Dr. Dorian Bosev, who was able to completely resolve the problem with the left ovary, which up until this day is okay.
Здравейте, казвам се Илона и днес ще отговорим на няколко въпроса, свързани с ендометриозата. Моята менструация си беше доста редовна, когато трябваше да дойде, си идваше като по часовник. Аз имах доста симптоми, много силна болка, по време на менструация имах изключително силна, болка по време на секс също, но не ми се налагало да пропускам работа. Случвало ми се да отида на работа с много силни болки, да съм неработоспособна. Ами в един ден прекрасен бях на работа, тъкмо приключвах работа, заболя ме корема ниско-долу от дясната страна. В майчин дом ме прегледаха, казаха ми, че имам киста и на следващия ден отидох при доктор Босев. Ами при мен започнаха, може би около половин година. Всяка менструация беше супер болезнена, както казах, и просто всичките симптоми си се появиха така изведнъж, но горе-долу 6 месеца.
I was 42 years old when I was diagnosed. My period was and it's still irregular. I had pain before and during my period, no energy, frequent lower back pain, pain during sex, if I must be precious in the area of the ovaries. I do not plan have more children. I'm a mother of 3. I haven't started hormonal therapy yet. I changed my lifestyle, started eating healthier, stopped drinking and limited sweets. I hope I am helpful. Thank you.
Hello, my name is Dr. Tsvetelina Popova. Around 190 million girls and women in their reproductive age are suffering from endometriosis globally. It's a chronic disease associated with severe pain during menstrual cycles, sexual intercourse, and sometimes developing anxiety, depression, and fatigue. Endometriosis has significant social, public health, and economic implication. It can be life debilitating due to the severe pain, the development of anxiety, fatigue, and depression. Some of the patients may experience such severe pain that they are unable to perform their daily routines, their work, and they have to miss work or school. Endometriosis can lead to avoidance of intercourse that will affect the individual and their partners. EndoMarch Bulgaria recognizes the importance of endometriosis and its effect on a person's well-being, their sexual health, and their overall well-being. We would like to raise awareness with endometriosis so that more patients can get the help that they would need. Thank you for your support.
on families and socially. And next year will be the 10th year anniversary of EndoMarch. We encourage you to continue to participate in the activities by going to www.endomarch. If you go to www.endomarch, you can download the previous webinars that we have addressed many issues, including diet, including health, including different organs involved with endometriosis. That webinars, it is on www.endomarch. Also, Worldwide EndoMarch has an app that it is completely free. We donated it to the Worldwide EndoMarch. It is called Nejat Endometriosis Advisor. Nejat Endometriosis Advisor diagnoses endometriosis with more than 94% accuracy on patients that they have endometriosis. And also they want to have children and they have not had children, and it is they have no or unexplained infertility. So EndoMarch and Nejat Endometriosis Advisor, that we can get that app for free from iPhone and also Google, Android. You can download it. So again, we like to thank you for your participation. And we have an outstanding guest group that Dr. Sina Nejat would proceed and introduce them. Dr. Sina Nejat.
Thank you very much, Dr. Cameron, and greetings from Atlanta. Years ago, Dr. Cameron Nejat mentioned endometriosis is the whole body disease. For years, we have been publishing, talking about surgical management, but realized that endometriosis could affect the entire body. And one area is the psychological impact and effect on the social condition of the individuals. If somebody has diabetes and tells people I have diabetes, they say, okay, if I have leukemia, it's okay, and they have all the sympathy. If somebody says I have endometriosis, they just throw their eyes off. And endometriosis could cause unseen scar on the mental and social condition of individual. So having that in mind, we thought on this session, invite a group of a panel, that outstanding panel. I am so grateful for them to volunteer their time. We have Nicole, who would share her story. We have Didi, who would have the child psychologist and therapist. And we have Dr. Minal Shah, which has extensive experience on dealing with psychosocial impact of the individuals. So what I like to do is start asking Nicole. I'd like to ask Nicole to start, tell a little bit about her story. And this is really informal. We just want our viewers around the world understand that awareness about endometriosis is number one, a step towards proper management. So Nicole, it's all yours.
Okay, thank you so much for the introduction, and thank you for having me on. Endometriosis is something that has affected my entire life from the time I got my first period. It's been a rather long journey, and so I'll try to condense it to the highlights of how it affected me. But it did affect me physically, emotionally, and mentally. And so I've spent many years trying to figure out the root cause of my many health issues. And it was quite a relief to find out that it stemmed from this one place. But my journey with endometriosis really started when I got my first period at age 12. The pain each cycle was pretty excruciating. I would have really bad lower abdomen pain, really bad back pain, and it would shoot down to my knees, and I could feel it in all my joints. So that's how I knew I was going to get my period soon, is that I had joint pain. It would shoot down my legs. And then ever since I can remember, I had really debilitating anxiety. My anxiety was out of control, especially in middle school. I went through a period where I couldn't even leave my house. I think I was in 8th grade, which is kind of old not to leave your house, but I couldn't socialize. I couldn't go to school. It was horrible. My mom would have to drag me to school kicking and screaming like I was a little kid. She's doing the best thing that she thought for me. The doctors were like, the best thing is to, get her on Zoloft and her to go to school, live a normal life. So in 8th grade, I would just go to school and I would sit in the principal's office all day just because I couldn't talk. I couldn't interact with people. It was pretty all consuming. And then going into high school, I significantly changed my lifestyle and diet. I was always really into exercise and sports. That seemed to help tremendously, but it was still always there. My anxiety was always lurking behind me. I was able to be more social, but I had trouble, spending the night out just because I didn't know when I was going to experience pain, when I was going to be physically sick. And then they put me on Zoloft. It was still a constant struggle. And then in high school, I started experiencing depression. It would come like a week before every cycle. And I don't remember it impacting me socially. I definitely didn't go to everything I would have. But it was something that people probably didn't want to be around me that week because I was extremely moody, irritable, and just would want to shut down and crawl into my bed and turn off the lights and not come out till it was over. And then in my mid-20s, I started getting extremely bloated and experiencing tremendous weight gain, and nothing was helping. It was getting worse and worse. I felt so swollen. I felt so lethargic. I am a runner and I work out pretty much every day, and I couldn't work out. It was just, my body was weighted down. I was just so tired. And I actually gained 30 pounds in a summer, whether that was weight and bloating, I don't know, but I was swollen head to toe. And then in just a little over a year, I went from a size 0 to a size 12 in clothes. So the whole thing of not wanting to go out, not being social. I mean, I couldn't wear my sweatpants out. Nothing fit me. I was constantly shopping, even the biggest sizes, I was bloated in weird areas, nothing fit. So that took a toll on me. It was very uncomfortable. And then it got to a point where my body weight, my depression came to a head, and then I needed serious medical attention and really needed help. So I saw many doctors. They all tried to help with my symptoms, but not find the root of it. So I went to one doctor and talked about my weight gain, and they tried to put me on Vyvanse or tried to put me on a stimulant. And I was like, but why am I gaining this weight? Why am I so depressed? What's happening to my body? I have no control over my life right now. And then I went to a nutritionist in Atlanta. She's really, really good. I was explaining my symptoms to her, and she said, it sounds like you have PCOS. So she introduced me to Dr. Sina Najat. I made an appointment with him. We had a long conversation. He wanted to know all my history, everything that was going on with me, not just physically, and it wasn't isolated to my body. It encompasses my mind, my emotions, how I was feeling. So after talking and doing the examination, he did diagnose me with PCOS. And then based off that, he thought that I really probably had endometriosis as well. So in October 2019, he did my laseroscopic surgery, and he diagnosed me with stage 4 endometriosis. And ever since that surgery, I see him every 6 months. I've been just doing so well. I have a really good workout routine. I've never had more energy than I've ever had. He put me on a hypoglycemic diet. He introduced me to Dr. Meenal Shah, which is my therapist, who has been a significant help as well to getting me back on the right track. And it's the first time in my life I feel like I've ever had control over my body, my mind, just feel completely stable in all aspects. And even my friends and my family, they're like, I don't know what happened to you the last 2 years, but you seem like a very different person. And I've always had good relationships, but I feel like it's just impacted my friendships and my relationships with my family even more, because I just feel like I have the energy. I've learned to love my body and everything that comes with it. And I think it's really important to take the time to find the right doctors. They're in a network, so they're going to introduce you to the right doctors and have your best interests at heart. And that's really, really my story.
Nicole, thank you so much for sharing your story, and very happy to be part of your journey, and you are doing so great. So stay with us, we will come back. So on that line, as you notice here, Nicole brought up a great point out that actually on the books that we published, and we have some patients have written their story, Dr. Meenal Shah has a chapter. We have looked at the whole body, and we call it the comorbidities associated with endometriosis. And for example, nutrition, physical activity, holistic therapy. So having said that, how would this affect our daily life and how we become a messenger, not only about our own health, paying it forward, and when on our daily activities, when we deal with the family members, oh, I had similar symptoms, so you may have endometriosis, like Nicole mentioned it. She talks to her family members. So I'd like to invite Dr. Didi Chatkels. She is a child therapist. And Didi, are you with us? Tell us about you. She is very well educated and having a center in San Diego. And Didi would tell us her story.
Well, first of all, Nicole, beautiful, beautiful explanation, and how brave you are to share your story. And thank you to the Najat family for including me in this. This invitation has really given me an opportunity to reflect on my personal journey and kind of see how it has impacted my life and my career choices and who I work with now. I'm a school psychologist at a little private school down the road where my twin daughters attend. And so my medical history is not as complicated as yours, Nicole, but there's definitely the same theme that you can see, running through all of this. I started my period in middle school. It was immediately very heavy, very painful. And then it became increasingly irregular. And so, very difficult to manage. So I would say in high school that I had a great family, great parents. I could talk to them. And so my mom took me to a gynecologist and they put me on a birth control pill to regulate my periods. And I think that was about in 9th grade. It could have been a little later. And that helped for a while, got me through college. And, but you kind of normalize the pain, you kind of normalize all the, what ifs during the time that you're menstruating. And what if it's going to be heavy? What if it's going to start early? What if it's going to keep going? There'd be times where I'd have 2 weeks, So, but you just kind of normalize it and live with it. And it wasn't until I would say the mid 90s, when I entered graduate school, that the pain became really increasingly unbearable. And I would say I was having a specific sharp pain on the left side of my abdomen and the uterus area. And so my gynecologist did an ultrasound, and they found a dermoid cyst on my left ovary. And this is prior to meeting Dr. Najat. And when they went in, they tried to do it laparoscopically, but ended up having to do an incision. And they found, very severe endometriosis and the polycystic ovarian syndrome and all the good stuff that explains a lot of symptoms leading up to that. And that is what prompted me to seek an expert. I was really, at that time, I was really concerned about fertility. I wanted to have children. I wanted to be a mom. So that is what really got me to Dr. Najat. And I've been a client for 20 years, over 20 years. I've had three surgeries in total. But when you talk about the psychosocial impact that had on me, now reflecting on what I've been through, the pattern of the three things come up: pain, persistent pain, low energy, and fear. And the fear is, you can kind of attribute low energy to sort of depression symptoms, but the fear was really something that I think goes unacknowledged for such a long time. And that can really have a major impact on, prognosis and life choices and, just living a healthy, happy life. So in my 20s, when I was given the diagnosis, there was a lot of relief because that explained all the psychosocial things that were going on. And since I had started my period, and then it helped me to understand and predict how I needed to go forward. So, the fear is obviously contributes to anxiety, high anxiety. I was put on medication in high school, which was more unusual than this nowadays. It's a lot of medicated people, a lot of medicated teens, a lot of teens needing some extra support. But it was unusual in the 90s, late 80s, and so. But it's the fear of being unprepared. That I was going to start my period when I didn't. Wasn't prepared, fear of, as a younger child, leaking on my clothes, being at school and having that, what if the boys see, or what if, something happens and my mom has to bring me another uniform, and it transitioned to, I did struggle with some bloating, some cystic acne, and so fear of a breakout, right before prom, or fear of those kinds of things, and fear of weight gain. Am I not going to be able to fit in my clothes? And all of that, kind of persisted through college. And then it was fear of not being able to have children. And that really put me over the edge of worry and concern and anxiety. And then along with that, it was the fear of, what if this turns into cancer? What if it turns into some kind of pathology that is going to affect me going forward? So having the right person, the right diagnosis and the right caregiver is so critical to maintaining your mental well-being while you're going through such a, you're having all these whole body symptoms, like you said, just it's affecting multiple areas in your body. It's affecting multiple systems. So all of those things, it's really interesting in retrospect to see how that impacted even my career. I knew I wanted to go into psychology. I knew I wanted to work with kids, and even impacting me as a mom. I have two amazing twin identical daughters who are 17 and they're seniors. And the irony of this entire thing is they are not my birth children. So as much as I wanted to, I was so fearful of not being able to have children, I was blessed with these two amazing daughters that that I didn't, have to go through all of the fertility treatments and what I potentially could have gone through given my diagnosis. So I'm thrilled about the increased awareness because that contributes to increased early intervention, and then obviously prevention of other issues that develop as long as you live with this disease. So that's my story. I still come home annually. I'm in San Diego. I come home annually to see my favorite doctor, and he knows my whole family and he's met my girls. And so what a blessing it is to have this increased awareness and prevention.
Didi, thank you very much. I appreciate your candid sharing your whole journey. And Didi always says, I will watch my two daughters and everybody that I deal with at the school like a hawk. And
oh, yes.
I wouldn't write off any of their symptoms. So stay with us. Let's invite Dr. Minal Shah. I've had the pleasure of working with Dr. Minal Shah for more than a decade. And what I realized about Dr. Shah, the same thing that I mentioned, she looks at mind and body together, the whole body disease. Dr. Minal Shah is the founder of the DBT. When I was talking to some of my patients, referring them to Dr. Shah, I said, she's the founder of DBT in Atlanta. They said, what the heck is DBT? It's interesting. At the University of San Francisco, they actually have the DBT center also, and one of the therapists has put something online, exactly the same title. What the hell is DBT? So I would refer you to that. It's funny, but it explains everything for you. On that line, I'd like to invite Dr. Shah to share her knowledge, expertise with us. Minal?
Thank you. Thank you so much for having me, and good afternoon, everybody. One of the things that we've noticed in the last over 20 years of practicing various forms of DBT is that many females, more than not, have had an onset of psychological symptoms in the 12 to 18 months pre-menarche. And a lot of the females have a severe worsening of symptoms in the 7 to 10 days prior to their menses every month. So it came to mind that it couldn't possibly be that people were just developing severe psychological symptoms, at the onset of puberty for no reason whatsoever. And the type of patients that we see, generally speaking, have parasuicidal behavior. They're cutting, burning, binging, purging, drinking, using drugs. They're very severe behaviors that can often lead to active suicidal completion, inadvertently even. So we started sending most of our females to Dr. Najat, who I will absolutely say, beyond a shadow of a doubt, cured them upon alleviating most of their reproductive and endocrine symptoms. Our work was cut down by a good 50 to 75% with each of these patients. So all of the patients that we have sent to Dr. Najat that have completed a solid year of treatment with us have gone into remission, most definitely in the psychological arena, but for the most part, from what I'm hearing, with their reproductive endocrine difficulties as well. So we are just so thrilled that we have a resource like Dr. Najat in our city, where we can send everybody one after the other. The vast majority of our practice does go to him. And I dare say that we have one of the absolute highest rates of remission and cure for the patients that come to DBT than of anybody. And I think it's because of him and the work that he does.
Aminal, thank you very much. Can you elaborate a little bit more about what DBT is, what your center, and I mean, you give lectures everywhere I see it. So for the general knowledge, I think it would be helpful if you elaborate a little bit more about the focus of your work and how, in general, you deal with the individuals. Yes, I get involved with the female part, the patient part, but you deal with their families also. So please elaborate on that if possible.
So dialectical behavior therapy was developed for the emotionally dysregulated patient that wasn't responding to other treatments. Patients that are pervasively emotionally dysregulated and patients that are pervasively emotionally lonely and shut down and non-functioning. So we have two sides of the same coin. Those with very big behaviors that are creating chaos in their lives. And we have those patients that are extremely shut down and not living their lives. Two different sides of the same coin. The DBT and RODBT really treat the patient through a set of modules that are skills-based. These are disorders that we are treating that are due to a lack of skills in coping, in functioning, in relationships, in work, in academia, in all areas of their life. So the great thing about DBT and its counterpart, RODBT, is that we teach skills on a weekly level, a weekly basis, one skill after another, building from the ground up, bit by bit. And it's incredible as an outpatient therapy because they learn something each week that's very tangible. And then they go home and they practice that. And then they come back the next week. And the efficacy of DBT has been shown to be extremely effective at the 12-month mark, a solid year of shaping behavior in, a solid year of shaping unwanted behavior out. Most of our patients do extremely well at the 1-year mark, unless, of course, they are fighting their biology, which is where Dr. Najat has typically come in for us. Predominantly, most females, most of the patients that come to us are going to be female. Most males with the kind of difficulties that our females have, generally speaking, land in jail because anger for men is very explosive and anger for females is generally turned very much so inward, right, in terms of self-destruction. So the predominance of our population is going to be female. And what we've noticed is that psychiatry as a whole has been just treating the symptoms day after day, year after year, decade after decade, just putting people on antipsychotics, antidepressants, mood stabilizers, and not really looking for the causes of what's going wrong with them. What I really love that Dr. Najat just mentioned is the holistic approach. DBT addresses that. We have a skill called the please skills, or what we call the my seed skills, sowing the seeds of health. And it stands for SEEDS, sleeping, eating, exercise, drugs, illness, medications. These things are what we look at holistically for each and every patient. So it's beautiful that we have a treatment that does that and tracks people's emotions in regards to what they're doing every day, the skills they're practicing every day, as well as their nutrition every day, as well as their cycles every day. This is a very comprehensive, broad, all-inclusive treatment that has complete efficacy behind it. And I love that. I love that. most of our folks are able to get off the vast majority of medications as well.
Thank you. Thank you very much, Dr. Shah. So as you notice, so we are talking about connecting the mind to the body, and eloquently, Dr. Shah mentioned it. And if you notice, we are talking about replacing behavior therapy or cognitive therapy with just simply throwing medication to the other medication. So Nicole beautifully explained this, put her on Zoloft, and they wanted to change it from one to the other. But her bloatedness, it was completely independent of her psychological effect. It was the bloatedness who was leading to her mood disorders or psychological impact. There is a condition called endobelly. You may want to look it up. It's interesting. It's kind of rare, but it happens. And endobelly is a direct effect of the endometriosis and this bloatedness. And interestingly, I was in American Fertility Society meeting, and I was talking, giving a seminar. And when I asked people, these are all physicians, reproductive surgeons, or reproductive endocrinologists from around the world. We had about 200 audience. And I asked them, do you know what endobelly is? None of them knew that. So look it up, especially I'm addressing this to our audience, the people who notice it. Endometriosis could cause bloatedness. And bloatedness is not because you decided to, out of a sudden, to gain weight or juggle on a cake. No, it's endometriosis. The weight gain could affect that. So tell me a little bit more, Nicole. You have a brilliant nutritionist, which I happen to know, and she knows about hormonal aspect, what do they call it, gluten intolerance, lactose intolerance. Tell us more about how this nutritional change in your life has impacted, and your knowing about your endometriosis has impacted your daily life.
Yeah, so when I was 15, I saw that same nutritionist, and she modified my diet to exclude gluten, dairy, soy, and egg. And I noticed a tremendous difference. Just more energy. I mean, not completely better, just more energy though. I wasn't, I was sick a lot. I'll spare you the details, but stomach wise, from what I was eating. So that helped a lot. And then when I started getting extremely bloated and the weight gain, that's when I really got very frustrated, because I was eating so healthy, so clean, gluten-free, dairy-free, soy-free, egg-free, very whole foods. And then when I saw the nutritionist again, I was like, I'm gaining all this weight, I'm working really hard, and it's just very discouraging because I'm going in the opposite direction. And I mean, I can't live my life like this. And then when she referred me to Dr. Najat, one of the first things he had me do was sit for a glucose test. And what the glucose test showed was that I'm actually hypoglycemic, which is linked to my PCOS. And so once I shifted my diet and shifted my lifestyle to incorporate a hypoglycemic diet, which is, you can eat very healthy, but everybody's different. So it depends on how you're going to respond to the food and how you're going to break down the food and absorb the nutrients. So when I switched to a hypoglycemic diet, it really changed everything. It gives me so much more energy. I feel like I have control over my weight, my bloating. It was hard for me to make plans before that because I never knew what days I would be extremely bloated and when I could or couldn't wear clothes. So it was hard to have a schedule. My friends always used to joke around with me because I would only make one plan a weekend. I couldn't have more than one plan a weekend because it would wipe me out. I couldn't go to dinner 2 nights in a row. I just couldn't have a normal social calendar for someone, a young single female. And so now I feel like my social calendar is bustling. I have so much energy. I can have plans every night of the week and just stay on track. I don't have to be so regimented and type A about my environment and my schedule, because changing my diet to hypoglycemic diet has changed everything, along with the surgery and then the weekly help from Dr. Shaw as well.
Great, well, thanks. So in addition to changing the lifestyle on eating, sharing your issues with somebody like Dr. Shaw, a counselor, a knowledgeable person who knows about the whole factors, not just to a therapist who would, or a psychiatrist who just wants to change one medicine to the other. Talking to somebody who knows about this background, don't you think it's been more helpful than the people you talked with before?
Yes, absolutely. I mean, I've seen multiple different doctors for each symptom, and they were all just trying to give me things to mask the symptom and reduce the symptom, but no one was really taking a holistic approach of looking at the whole body. So having doctors like you and Dr. Shaw, someone that looks at the mind and the body and how it's linked, has been a tremendous differentiator in my life. So thank you.
Thank you, Nicole. So the take-home message from what Nicole says is, take no for an answer. If they tell you it's in your head, it's not. If they want to put you from one medicine to the other, my compliments to her. She changed nutritionist until she found a person with knowledge. She changed doctors until she found somebody who could take care of it. And she gets the therapist. So if somebody is doing the same thing for you and you are not getting the results, it's always good to get a second opinion. Having said that, we go to Didi. Didi had the same experience. Tell us what you think.
Oh, I think it has been the amount of relief when you keep searching and you get the answers and it all makes sense. All the puzzle pieces are put together, and then life feels much more manageable, and you have the people that you know that you can depend on, because at least that part you can control somewhat. You can control who's in your life and who you listen to, and make sense of, help make sense of what's going on with your symptoms. And when there's so much other things in this world we can't control, and especially the kids today, the teenagers that I work with, they have so many stresses and so many different things that I never had to deal with social media and all of the different stresses that go along with being a teenager now. It's so hard. So definitely there is hope, and this increased awareness, I think, is going to change the trajectory of a lot of people's lives, as far as preventing that place that you can go to that's so dark, and it's medication after medication after medication. And so again, the increased awareness just leading to prevention of these things is just fantastic.
Well, great. Thank you, Didi. Didi brought up a great point out, and I've heard it all the way. It says verbalize and vaporize. So Didi mentioned one important point. A good relationship with the family and family members, not holding it in or stuffing it, it's not good. Talking with family members and educating the family members. One thing is unique about family, Didi's family, she said it, she's open-minded, her family, they spoke together, and actually her godmother, her mother's best friend, who knows where I live, actually called me.
She did.
She said, I want you to see Didi because she wasn't getting better.
Yes.
So that was a great point you brought up. Ask for help. Don't stuff it in. It really becomes an old scar. And talk to your family, talk to your friends, and look for help. Dr. Shah brought up, go ahead.
Normalizing pain, normalizing this bloating and weight fluctuations and horrible breakouts and just pushing through. You don't, that is not, it's not normal. It's being okay to say, I don't think something's right, can make such a dramatic impact in your future and in your life.
So when you talk to the children you deal with, you are looking at them and you lead them to the direction and you bring it up, so it affects your daily work also, doesn't it?
Yes, and it's funny. We have some fantastic teachers, and I just had a conversation last Friday with one of our kindergarten teachers and she was explaining some symptoms and what she's going through, and I said, oh my gosh, I think you better explore, this option. Maybe you have endometriosis. And and then one of my dearest friends and colleagues at work too, she was worried about her daughter, and I was like, wait a minute, this sounds a lot like endometriosis. And so even with, it's not just affecting the kiddos that come into my office, it's also my colleagues, and seeing the younger teachers start to struggle with things in their childbirthing years and then child rearing years. So it's been such a huge blessing to me to have the right people that have educated me and have taught me how to manage my symptoms, and through diet and exercise and supplements and therapy and just talking to the right people, and it's possible. I mean, I'm very healthy. I feel great. I come home, I go home every year, and I get my fix, and I get my physical, and I'm in Atlanta, and I see my family, and I see Louise Poor and who got me to Dr. Najat, and it's great, but just keep searching for the right people.
Thank you again, Didi. And Dr. Shah brought up a great point out, which is very important. She mentioned the male, they have different type of behavior than the female. And the female, they become more internalizing it, and they become more self-destructive. This is a great point. We have to look at it. She mentioned different manifestation of self-destructive behavior. One of them could be eating disorders, eating the wrong food, or other aspect. Dr. Shah, this is a great area, and I think we see it very often on our patients with reproductive disorder, mainly endometriosis, fibroids, the hormone imbalance, etc. Could you please elaborate on that?
Absolutely. One of the interesting things that we've really noticed as of late is with anorexia, which of course has the highest mortality rate in all psychiatric illnesses, with bulimia, with sleep disorders. Of course, sleep disorders are the #1 indicator of whether or not you will achieve remission in psychiatric illnesses. One of the things that we've noticed is obviously all of these things are driven by hormones across the board. I'm not just talking about reproductive, but hormones in general, correct? So, I mean, correct, right, Dr. Najat? The body is run by hormones.
That is correct. There is a direct relationship between the hormones and the physical conditions. So we know, for example, the pituitary controls the pancreas, the adrenal gland, the ovaries, the thyroid. We call it, these are all associated disorders, and one leads to the other. You are absolutely correct. Please elaborate.
And one of the things that we noticed is, and I'll give you a very, very benign example, is if somebody was drinking too much orange juice with vitamin D and they were not sleeping well at night, they might not know why they're not sleeping at night. And now we're giving them sleeping pills, and nobody's taken a history as to why they're taking so much vitamin D into their body. And of course, vitamin D is activating, right? Not sedating. And we know that, but people don't know that in general. So one of the things that we'd really like to see is with every disorder that comes in our world, be it everything in eating disorders, be it anything in personality disorders, be it depression, we would like a full endocrine workup, not just reproductive, but a full endocrine workup, head to toe for every single individual, because we see that even in males, they often have an undiagnosed endocrine difficulty. I mean, I know we're here for endometriosis and PCOS and fibroids, but the fact of the matter is that this is all endocrine driven, hence these wonderful gentlemen are reproductive endocrinologists. But I would like to expand this awareness to all endocrinology, the greater umbrella under which most things are occurring. And most psychiatric diagnoses are diagnoses of inclusion and not diagnoses of exclusion. So once somebody sees 1 or 2 or 3 symptoms, they say, oh, she's got major depressive disorder, and starts throwing pills at it. And nobody really looks for the cause of what's going on. Nobody really looks to exclude any symptoms from a diagnosis. And I think that really very much needs to happen for both genders, to be very honest, in order to adequately treat patients.
It's a great point. And remember now, when we talk about gender, it has become more, I would say, common now that we have transgenders. Yes. And we just can't focus just on the female part. And that could affect the individual. So we have to validate, as you mentioned, the hormonal aspect, regardless of the chromosome. We have to look at the whole area. And that was a great point you brought up. And
we have watched several trans men, people born biologically as female, have many reproductive difficulties, from PCOS to PMDD to endometriosis, that have, through very significant emotional difficulties, made the decision to transition to being a male. And unfortunately, that doesn't get rid of the problem that is causing the emotional dysregulation in the first place. Okay. So I really think that a heightened awareness for individuals who are trans male is really warranted in the reproductive endocrine communities.
Yeah, and I believe you see quite a number of those, don't you?
We do.
So this is a great message to send it across, that when we are talking about, again, going back, that endometriosis is a whole body disease. It not only it could affect the XX chromosome, it could affect, change regardless. And we have the opposite too, that if the male wants to convert to female and they give them high amount of estrogen, for example, to convert them, that could impact the cells, embryological cell that they are in the body. On the book that we wrote on adolescent endometriosis, we have a chapter that did an autopsy on the fetuses, and they found out that they had endometriosis cells on the preborn fetuses. So if we need to be aware of it, that if we give these people hormone, it could impact their physical condition also. And today we actually have some of our fellows participating. It's been a greatest discussion. Please stay. We would like to have you the last message you'd like to give across. But before we go there, we want to see if any of our fellows who are online would like to give some point. I see Karen is on, Karen Hood. If I see her, maybe there are more on. I'd like to welcome you and get your opinion about this. And this is Dr. Dedmon. She is my fellow also. If you'd like to say something, you are welcome to do that. Amanda, you are muted.
There we go. Hi, thank you so much for sharing your stories. It's been really enlightening to hear from people who are affected and people out there treating our patients with endometriosis and addressing, not just the medicine of it, but also, the full body and not just the surgery. And so that's been really great to hear. I appreciate you all. And I think it really goes to show how important it is to start early in addressing these symptoms because, Nicole, you suffered for such a long time before you were able to find relief and to educate people. And is the purpose of this today is to educate people and try and get more people involved in seeing this early. And so I think that's been great.
Thank you, Dr. Dedmon. Karen, are you there? You'd like to say something? Okay, so having said that, before we pass the podium to Dr. Cameron Nijad, I'd like to ask Nicole, Didi, and Dr. Shah, give us your take-home message. What's your message before we finish?
Mine would just be to listen to your body, and just because someone is a professional, if it doesn't feel right and it feels like you're just a number to them, keep searching for doctors that are going to take the time to listen and sit down and call you at home and go over the results that you have, the good, the bad, the ugly. You don't have to be dying to have time out of their day. So I would just say, follow your gut, listen to your body. If someone's telling you that you have something and it just doesn't feel right, or if you're not getting the proper treatment or time of day from your doctor, there's other really good doctors out there that are going to search to find the root and really make you better from the inside out.
Nicole, thank you so much. I know you were busy and really had to get this done on your schedule. On behalf of all the people who watch, I really want to thank you for volunteering your time. Didi, your turn. What do you think?
I would agree with Nicole. Just speak up. Don't lose hope. And to really try to seek somebody that if they are not aware of whole body treatment, that they can get you to somebody that can put the whole puzzle together for you and support you in that way, and as opposed to just being so narrowly focused on hormones or depression, or so narrowly focused on one symptom, because again, it does affect your whole body, and that there is hope, and that you don't have to push through all of the pain, and you can have babies, and you can feel great, and you can have a full life, even with this, and managing this is possible. So, and thank you for having me.
Of course, Didi, thank you so much. I know busy mom and busy work and wife, and is putting it in your schedule. I'm really grateful.
Oh, I wouldn't miss it.
Thank you. And Dr. Shah, I know you had to cut your travel short to be here, and I'm really grateful for all you are doing for all these patients and for all you do everywhere. But we'd like to hear your take-home message.
Well, first of all, my gratitude goes both ways. My patients come crying to us with relief because they have finally met you and finally have a solution in sight. My take-home message really has two parts to it. One, to patients, we are the one field of medicine that is paid to listen. And if you don't find somebody that knows how to listen and put all the pieces of the puzzle together, don't spend years with that person just describing your woes week in, week out with no relief in sight. For the professionals, what I want to say is, again, we are the field that's paid to listen. And unfortunately, the field of psychology has not been educated well enough to know what to listen for. So I believe, and I've noticed this in my trainings across the state that I'm doing for all of the hospitals, that almost every clinician that graduates as a counselor or psychotherapist has no idea of what to look for any illness, much less reproductive illnesses, for all of their patients. And as I'm teaching them about medicine and endocrinology and sleep disorders, their eyes are opening up very wide, and they're like, we have never considered all of these things. And they start coming up with multitudes of patients that they realize could have been helped much more effectively, much sooner, had these things been addressed. So I would like the move to be made, the push to be made for clinicians to have a more well-rounded education, because being the field that is paid to listen, we need to know what we're listening for.
Great, thank you so much. And one thing you brought up, and I really want to take this message to all the therapists, that you said we have to get away from inclusion, diagnostic inclusion. We have to also focus on exclusion. And that's the key factor. Really, that was eloquently said, and I like to echo that. So I'm so grateful to all the panelists for taking the time for being with us. And I like to thank everybody around the world who is listening and taking this message forward. And we'll pass the podium to Dr. Cameron Nejad, the founder of EndoMarch. This was his idea to start this. And Cameron, all yours.
Thank you very much, Rashida. So this was a fantastic session. We thank you and all of your guests. Every one of them was better than the other, and the information was very, very helpful. I have no doubt that more and more people will continue to look at this and view this, and will be very helpful to the participants. And we thank all the participants for their interest, and all of you around the world for EndoMarch. And we look forward to your participation and your activity to put an end to the dynasty of endometriosis. More and more good news every day is coming. Since the worldwide EndoMarch, the awareness started 10 years ago, and endometriosis is being recognized, more publications, more diagnostic tests. So we thank you, and we look forward to the future session. And also I thank all the people at the Worldwide EndoMarch headquarters, Barbara Page, Zoe Pennington, and all of the assistants. I don't want to name one by one, Melanie and Michelle and Leslie. I don't want to forget many, and we thank all of them. We appreciate it. We look forward to seeing you. And thank you very much, Dr. Sinan Najat, and all of your guests. Thank you. Bye-bye. Forward we go.
Forward we go. Thank you very much.
Thank you.
Bye-bye.
Good morning to everyone. Thanks for this opportunity to share with you my experience on treatment of bowel endometriosis. Thanks for inviting me. So, the bowel surgery and how to tailor an approach to treatment of bowel endometriosis. So, first of all, we have to start from a correct management in reference center. So, starting from a correct anamnesis and clinical evaluation of patients and skilled imaging in order to understand the localization, the sites of the disease, and then we can put the correct indication from a clinical management of the disease. Then a complete counseling with patients with informed consent, and then, of course, we have to push on surgical experience and knowledge of anatomy and neuroanatomy and postoperative evaluation of the patients and management of postoperative complications. So, starting from the consensus of on Strasbourg on September 2022, we have to consider that all the asymptomatic patients should not be operated, and in case of surgery, in case of pain symptoms, and so as we consider the surgery like treatment, we have to improve the pain and the quality of life of these patients. Starting from the imaging with the pelvic MRI or transvaginal ultrasound, based on experience of radiologists or sonographer, they are very accurate and consider the intraoperative findings in order to avoid to upstage or downstage the disease. The surgeon should be very complete as possible in order to have at least a visual disease-free margin of the disease. It's better to avoid to dissect the nerves if we don't need it, and if bilateral infiltration of the parameter considered to leave some disease on one side. Avoid unnecessary dissection at the level of the nerves, and try to be as conservative as possible. When not feasible, we have to proceed to segmental bowel resection. And fibrosis seems to be a part of the disease, so we have to remove the disease at the level of the fibrosis in the muscularis of the bowel. So, starting from the preoperative workup, consider a pelvic MRI or transvaginal ultrasound, urodynamic tests in case of urinary tract dysfunction or suspicious of neural plexus involvement. We never ask for colonoscopy because the disease never arrive at the level of the mucosa. We don't need colonoscopy for the diagnosis. We never ask for double contrast enema because we can evaluate the percentage of stenosis with a very good transvaginal ultrasound. So the key question is to stay in the mind of the surgeon. So speak the same language between sonographer, radiologist, and surgeon, and consider that with transvaginal ultrasound and transabdominal ultrasound, we can evaluate all the rectal junction disease, the sigmoid, and the Shandon colon, and on the right side, the right colon, the second, the ileocecal junction, and the appendix. And this is the picture with ultrasound. On the picture A, we can evaluate the sites, the craniocaudal sites of the nodule with infiltration in the muscularis. In the picture B, we can evaluate by ultrasound the transversal sites and the circumferential involvement in picture D. And the most important evaluation is the millimeter of infiltration in the muscularis in picture D. About the indication for kind of surgery, for shaving, discoid, or segmental resection, we have to take in consideration the sites, the craniocaudal sites of the nodule, the infiltration in the deep of muscularis, the number of the lesions, and the circumferential bowel involvement. Our specific indication that we published on 2020 is based on the inner of infiltration and the craniocaudal sites. All the nodule less than 3 centimeters with infiltration less than 7 millimeters can go to the shaving. All the nodule less than 3, more than 7 millimeters go to discoid resection, and all the nodule more than 3 centimeters with infiltration less than 7 go to shaving, and the nodule bigger than 3 centimeters with infiltration more than 7 millimeters are candidate to segmental bowel resection. And so consider all these kind of lesions. It's a plaque more than 3 centimeters. It's around 7 centimeters of plaque in the muscularis, but the infiltration at ultrasound is less than 7 millimeters. So we know before the surgery that we can do a conservative treatment, so we can remove completely the endometriotic tissue and the fibrosis at the level of the serosa and the muscularis with this kind of approach. So a sharing technique using monopolar current with precise dissection, monopolar coagulation very close inside the muscularis in order to remove completely all the disease, and if needed we have to reinforce at end with a single stitch at the level of the serosa and at the level of the muscularis. So in case of infiltration, of the disease, more than 7 millimeter with the sides less than 3 centimeters, we can do this discoid resection. And so the technique, consider this rectal nodule at 7 centimeters from anal vert. The nodule is not so big, it's less than 3 centimeters, so we can do this kind of approach, involving the nodule at the level of the circular stapler, and then we can remove completely the anterior wall of the lesions of the bowel involving the lesion. At the end, we can evaluate with monochromatic approach or overlay approach with injection intravenous of indocyanine green and evaluation of the vascularization. And this was our publication about the technique of discoid resection. Again, we published in 2020 our classical technique for segmental bowel resection for all the nodule more than 3 centimeters with infiltration more than 7 millimeters. And this is the approach how to arrive at the level of the nodule, starting usually from the left side. So we arrive on the left side to evaluate, of course, the retroperitoneal approach and anatomical landmarks, the ureter, of course, the IP ligament, the external and internal iliac vessel. Then we can evaluate the hypogastric nerve and opening the medial parietal space, the so-called Okabayashi space. Then we don't need to push or to pull on the nerve. We stay medially in this area in the avascular plane, and we can prepare the medial parietal space with this kind of approach. In case of traditional technique, at the end of the resection of the nodule, we can do this kind of classical approach with the mini laparotomy approach with Alexis, and then we perform the end-to-end reanastomosis. This is the classical technique. At the end, of course, evaluation of the specimen in order to compare the preoperative ultrasound with the specimen in order to understand our accuracy at the ultrasound. On 1,450 segmental bowel resection performed in our center in 17 years, these are our complications. So rectal bleeding 3.2%, anastomotic leakage 1.6%, stenosis 1.3%, and rectovaginal fistula 0.7%, with 19 bowel dysfunction, constipation, frequent movements, and defecation pain regarding only the first weeks after surgery. Then we started 2 years ago to consider a total laparoscopic resection with intracorporeal anastomosis, the so-called nose, as alternative to abdominal mini laparotomy for extracorporeal anastomosis and specimen retrieval. So in literature, we consider that we have many papers, randomized trials, systematic review, and meta-analysis regarding the approach with nose for colorectal cancer that support that nose should be preferred to transabdominal specimen extraction for the lower rate of postoperative pain, shorter time for gas passage after surgery, decrease, of course, of hospital stay, better cosmetic results, and lower rate of wound infection and incisional hernia. The problem at the beginning that we consider for colorectal cancer was implantation of tumor and at the specimen extraction site, but on 3,400 patients on 19 studies in this pooled analysis, the total recurrence, local recurrence, disease-free survival, and overall survival showed no difference between the classical technique and the nose technique, and the same regarding the risk of bacterial contamination of the peritoneal cavity. On 2,112 patients in 21 randomized clinical trials, the infection rate on the ileus show no difference in between the two techniques with nose and classical technique. About the experience of intracorporeal anastomosis and nose technique for treatment of bowel endometriosis at the moment is very, very limited. And in literature, the transvaginal approach with nose show only 124 cases with this rate of complication grade 3. And if we consider that the transanal natural orifice specimen extraction, the classical nose is the same, 124 cases in literature with complication rate grade 3 reported on the right side. So our technique of nose that we published 2 years ago in 2021 is this technique. We arrive at the level of the caudal part of the nodule and we do the transection or the total transection with ultrasound instrument, with harmonic. We completely resected the rectum. We need a very good preparation, and then we resect again the cranial part of the nodule, cranially to the nodule, in order to resect completely the segment of the sigmoid and the rectum involved by the big nodule, more than 3 centimeters, with the big infiltration more than 7 millimeters. Then these specimen inside the bag go outside through the anal view, and with a transanal insection in the back of the spike. The anvil go with the spike in the cranial part of the rectum, then we remove the spike and we close the hole only with a 12 millimeter port and linear stapler in order to close completely the hole in the opening of the bowel, and then we close again the caudal part of the rectum like this with another linear stapler, and then we have only to perform the end-to-end on the lateral to end anastomosis with the circular stapler. At the end remain the so-called dog ear on the lateral part. We cover with single stitch in order to reduce the tension and cover the angle of the reanastomosis. The test with the gas, with air test and blue of methylene in order to evaluate the risk of leakage. And at the end, the overlay evaluation and the monochromatic evaluation with androgen green injected intravenous. And these are our 40 patients for the moment in less than 2 years, and the results was no protective ileostomy or colostomy. All patients received a complete removal of all the visible endometriosis lesions, and both received 5 days after of antibiotics after the surgery. The time of the surgery, the blood loss, the intraoperative complication, only one postoperative complication regarding an anastomotic bleeding, treated by endoscopic management, and passing gas after surgery with the median of 1 day, and passing fishes after surgery with an average of 4 days, and hospital stay 5 days of So the pro and the contrary of transanal nodes for deep endometriosis are the lower overall and wound complication rate, better cosmetic results, and potential for decreasing of hospital stay. But we need a specific train. We need a randomized clinical trials available, and is not yet standardized like technique. So in conclusion, we can say that endometriosis classification system is mandatory in order to speak the same language between the sonographer, the radiologist, and the surgeon. Appropriate indication for medical treatment, pregnancy, surgery, or follow-up, and surgical strategy with the correct surgical indication for shaving, discoid, and segmental resection based on preoperative imaging evaluation. And appropriate counseling with patients, try to centralize the patients in a high volume reference center. Thank you so much. Really, thanks. Thanks for your attention.
Hi, I'm Linda Giudice, and I'm delighted to be here today. Let me do my screen share so you can see some of the slides that I'm going to share with you today. And this is a very exciting conference, founded over a decade ago by Dr. Najat and supported over the years by the Najat Family Foundation. And the worldwide EndoMarch has really put endometriosis on the global stage. It has brought people together, and at these conferences, and certainly through social media and other mechanisms, making new friends and seeing old ones. So today I'm going to talk with you about a precision medicine approach to endometriosis and some of our research. And I think everyone here knows that endometriosis is a local and systemic inflammatory disease. So inflammation certainly in the pelvis with pelvic disease, but also inflammation outside the pelvis in many patients. And this is driven by estrogen, and endometriosis has an abnormal response to progesterone. And progesterone is really critical for counteracting the effects of estrogen. So if it's not doing what it should be doing as a steroid hormone, then it's not effectively counteracting the effects of estrogen, which then can make the disease and the inflammation increased. As you know, it's mainly diagnosed by symptoms, surgery, and imaging, and currently there are no non-invasive biomarkers, which have led really to a long latency from symptom onset to diagnosis, although there are several in the works. The risk of developing endometriosis has genetic and environmental components, about 50% each, and the disease has different presentations in different patients, has highly variable disease lesion types, as you can see here. Not only the three classical types of endometriosis, endometrioma, deep infiltrating disease, and superficial, but also what the lesions look like and the cells that they contain are different. It has unpredictable responses to medical and surgical treatments, and an unpredictable timeline for return of disease and symptoms, and has unpredictable co-conditions, comorbidities, such as hypothyroidism or autoimmune disorders. So overall, endometriosis is a complex and puzzling disorder. And today I'd like to review with you some new inroads trying to understand this puzzling disorder through precision medicine. Well, what is precision medicine? It's essentially a knowledge network of genomics, the microbiome, exposures, behaviors, clinical tests, and participant-contributed data that interfaces with social determinants of health and the environment. And as science and technology are rapidly advancing in many fields, integration of multiple approaches, such as shown here on the left, holds promise to answer questions about complex disorders. And I think we agree that endometriosis is a complex disorder. So precision medicine is leading the way to resolve complex clinical challenges and disparities in diagnosing and treating diseases across diverse populations, and has recently been extended to endometriosis. Our team works on multiple omics, such as genomics and epigenomics and proteomics, but we also work on drug discovery and electronic medical records in diverse populations. And we also work towards education and advocacy with the long-term goals of understanding individual risks of developing endometriosis, individualized therapies, so that it's not a one-size-fits-all, novel diagnostics for early diagnosis, novel therapies, individualized risk of recurrence after therapies, and individualized well-being. Each patient is different. So we have a center. It's the UCSF Stanford Endometriosis Center for Innovation Training and Community Engagement, Discovery Innovation Training and Community Engagement, called ENACT. It has 3 research projects, one on single-cell transcriptomics and immunomics, looking at the immune system. The second is a project on the proteome, exposome, and metabolome that you'll see shortly. And project 3 is more focused on drug discovery. Now, if we are looking at exposomics, we are fortunate to be able to collaborate with the Environmental Research and Translation for Health Center, so-called Earth Center at UCSF. In addition, we have an educational core that focuses on communication and community outreach. And here we work with the UCSF National Center of Excellence in Women's Health and the Black Women's Health and Livelihood Initiative. In addition, we work with the California Department of Toxic Substances Controls, and the research that we're doing is supported by multiple cores. Also, we collaborate extensively with the UCSF and Stanford gynecology and minimally invasive gynecologic surgeons, and we have had a long-standing collaboration with Dr. Najat and the Cameron Najat Institute. And we collect tissues, and our surgeons recruit patients and help us recruit patients, and Dr. Najat has been a major contributor over the years and currently as well. And the tissues we look at are the lining of the uterus, the utopic endometrium, endometriomas, superficial disease, and deep infiltrating disease. And we look at tissues and we look at blood. And very importantly, we need to understand what menstrual cycle phase does the tissue come from. So there are, and other things that are in so-called metadata or clinical data that are all de-identified and confidential. And we interface with our patient community. So the first project, as I mentioned, is looking at the lining of the uterus and the various lesions at a single cell level. This is new technology, and we are now looking at every cell, all the genes that are expressed in every cell. And it's not just looking at the cells. We want to know how they communicate with one another. And there are algorithms to be able to decipher that. Also, disease-associated states and markers and pathways, which are really critical for understanding this disorder. In addition, we're looking at immune profiling in the diseased tissue and the peripheral blood using different kinds of single-cell technology. And then once all these data are accumulated, the computational scientists do unsupervised machine learning analyses to identify disease subtypes, which is currently something that is not well understood. In the second project, we're looking at proteome analysis of lesions and utopic endometrium and blood. And we're also looking at the exposome by mass spec and the metabolome. So what kind of environmental chemicals are in the circulation? There's quite a literature on this, but we are doing this across the menstrual cycle and in patients not on any hormone therapies. And once again, our computational approaches are key to assembling and interpreting these data. And the third project has the goal of identifying and validating novel therapeutic candidates. Well, how do we come up with these candidates? We've done some preliminary data looking at the whole transcriptome, not yet single cells, but looking at the transcriptomics, which give us pathways in the various cells in the tissue. And there's a whole database of cell types, mostly in the cancer literature, where the pathways have been identified, screened with a variety of drugs, and anything that reverses the pathway is a so-called hit. And we fed the data from the utopic endometrium, the source of the disease in the pelvis and the source of pain eventually and inflammation, and found that there were several hits that, as you'll see shortly, essentially reversed the drug signatures. So the other piece of this is if you find a hit, then to validate it in animal models. And the endometriosis rat model is one of them. So the top hit for disease signaling reversal that we found was phenoprofen, excuse me, which is a non-steroidal anti-inflammatory drug that's commonly used for pain relief and has been used in a few trials to treat dysmenorrhea, a common symptom of endometriosis. And it also performed better than aspirin, a drug that is sometimes used for endometriosis. And just recently, using this rat model, we found that phenoprofen and ibuprofen almost identically decreased the pain associated with endometriosis induced in the rat model. So this type of work takes a village. This is the team. It's an amazing group of individuals who are totally dedicated to research on endometriosis, communication, advocacy, and access to care for patients who have this disease. Our education and community outreach core focuses mainly on San Francisco marginalized communities, sociodemographically, by race, ethnicity, transgender men, teens, and we've now extended to Columbia University in New York. Our center offers opportunities for collaborations, new research projects, mentoring, training, and advocacy. So I'd like to thank you for your attention, and I want to thank again Dr. Najat and the Najat Family Foundation for their continued support of the worldwide EndoMarch and sponsoring this event every year in March, Endometriosis Month, and also for the hearty collaboration that we have had and continue to have in pushing the envelope, trying to crack the endometriosis nut. So thank you once again.